Yes, ma'am, go ahead.
So, a very good evening to all of you. Welcome to this Foxy ICOG certificate course on adolescent health. That is on 28th, 29th, and 30th, 3 days certificate course. And so, to start with, I'm very thankful to, first of all, Dr. Sunita Tandurkar, Madam, who, President Foxy, who has in spite of her busy routine, she has joined. So show me her CVs, Dr. Nilima.
Supriya, don't waste time in CV of mine. Na? ICOG is all academic. I humbly request
So
our
today is
own
day one.
people.
Okay, ma'am. So today is day one,
Supriya,
and we.
Supriya, let's put the prayer song first and then let's start it.
So Nilima, just start with the prayers. For every academic thing, we start with blessings of God.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you so much. Now, may I request our President Foxy, Dr. Sunita Tandurkar, Madam, although I will just a brief CV, 2 minutes. Madam,
Priya, please. No,
Madam,
this
President
is
Foxy,
ICOG is always an academic session, and I don't think we should be wasting time in wrong things. First of all, I congratulate ICOG for doing many certificate programs. The team Parag and Sarita, I'm seeing they are involving so many academicians as a conveners, as a faculty, and that gives a feeling to every Foxyan that Foxy belongs to them and they belong to Foxy. So this is very, very important. And I went through the 3 days program series. And first of all, you selected very good conveners also, having a passion on the subject, Dr. Sampath Kumari, Dr. Supriya, and Dr. Durga Das. But what is most important I saw is the faculty which you have selected, past presidents, the secretary generals who have interest into the subject. And I really appreciate that. That is what the completeness of ICOG, completeness of an academic program. And Parag, congratulations. Whenever possible, I like to always join. Dr. Durgadas, hope to see you back in action from the hospital. मैं हर फॉक्सियन की ख्याल रखती हूँ कौन हॉस्पिटल में है कौन घर पे आ गया कौन डिस्चार्ज हुआ we do the prayers for all of you and you all should know the prayers have strong meaning and we could pull out Dr. Manish Pandya from a deathbed. So thank you so much again once more for having me as a small part. Lovely to see Vaishali also, Poonamji, Patanjali, Devnaya. So, thank you. Thank you for always being there for a Foxy and for ICOG. Thank you.
Thank you, Madam. A huge round of applause for you for coming, joining on the day one. And we are very much encouraged by just a flash of a second. You come, join, and encourage all of us. We are very thankful to you. Thank you, Madam. And now,
Thank you. Thank you, Parag. See
Thank you. Thank you, Sunita.
so moving ahead, I'm actually very, very thankful to Dr. Parag Biniwale, Dr. Sarita Madam, who have initiated this so well. And I request Dr. Parag Biniwale, sir, to kindly, who is the chairperson of ICOG, to kindly welcome the guest.
Yeah, thank you, Supriya. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to address the audience today with this edition of certificate course, and that's on adolescent health. I'm really happy that the president, Dr. Sunita, could join and could have a dialogue with us. I must appreciate the efforts put in by all three conveners of mine, Dr. Sampath Kumari, who way back in 2018 approached me when I was secretary of ICOG to initiate this program. And Sampath, I still very vividly remember the first training program that we took in Chennai in 2018 in the OGSSI office, where there were about 25 to 30 people from Tamil Nadu who had traveled on their own, and they spent the entire day discussing the various aspects of adolescent health. So I really appreciate your commitment, and even this is your 8th year as a convener
Yes.
of this activity. We are really proud of your work. I
Thank
would
you,
also
Parag.
like to appreciate Dr. Durga Shankar Das, who's our governing council member and the current chairman of Adolescent Health Committee, Dr. Supriya Jaiswal, for putting in a lot of efforts, ably supported by the incoming chair and the coordinator, Dr. Supriya Arwari. Welcome and congratulations, Supriya. So next year you will be one of the conveners of this program for sure. Of course, Dr. Poonam and Dr. Radhika Gauri, who have worked tirelessly for last uh, 3 or 4 weeks. A special thank you and special mention of Dr. Patanjali Dev Nair, who's one of the doyens of adolescent health. And when we utter the word adolescent health, it means Dr. PDN Nair to us. The passion he has about the subject, have not seen any person with so much zeal, enthusiasm, and he was the one who trained me almost 20 years ago in adolescent health. And sir, we are really thankful that you accepted our invitation to be a part of this program. So next 3 days are going to be action packed. We have all people who are passionate about adolescent health who will be part of this program today. And today we have already crossed 600 plus registrations. And for all the delegates, please attempt the post tests, because if you attempt all 3 post tests and secure more than 50% mark, you are eligible for a certificate from Foxy ICOG. So thank you very much. My best wishes for the program and happy learning to everyone. Thank you.
Thank you very much, Dr. Parag sir. And
Supriya, 1 minute. Parag, really thank you from the bottom of my heart. First program was in person in IOG, and consequently we are doing.
I think our connection is disturbed. Anyway, let's go ahead.
so I can't see Dr. Suvarna Khadilkar Madam, Secretary General Foxy. So
Ma'am, Suvarna Madam joining in between, okay?
okay, she'll be joining. So okay, then we move ahead. A few words from Dr. Sarita Madam.
No, I think Dr. Supriya, I'll be welcoming on the third day. So go ahead.
Okay, thank you, ma'am. So once again, thank you very much. All the faculties and the conveners, Dr. Sampath Madam, who is the pioneer of adolescent health, Dr. Durga Shankar Das sir, and the three coordinators, Dr. Poonam Lal, Dr. Supriya Arwari, and Dr. Radhika Gauri. I welcome all of them. And now the flow, we'll start with the flow. So Dr. Durga Shankar Das, he is the convener on day 2. He is the governing council member, and Dr. Sampath Kumari Madam, who has already been the chairperson of Foxy Adolescent Health Committee previously. And so the overview of day 1 topics. So day 1, one sec. So day 1, we have got 10 speakers, and the topics are all very, very interesting. Dr. Supriya Arwari, Dr. Sarita Bharerao, myself, Dr. Suvarna Khadilkar, Dr. Niharika Alu, Dr. Priya Vora, Dr. Patanjali Dev Nair sir, Dr. Chandan Kachru, Dr. Hema Diwakar, and Dr. Meenakshi Bharat. So these are they're very interesting topics: nutrition in adolescent, metabolic syndrome, then LGBTQ, primary amenorrhea, precocious puberty, how to set up adolescent clinic, that is very important. Then adolescent sexuality and mental health, the deep connection, a very important topic these days. HMB, heavy menstrual bleeding in adolescents, PCOS in adolescents, menstrual hygiene, post test. After finishing all this, we have to have the post test, and that is so. These are few instructions to all the participants about post test, the MCQ test. Delegates of Foxy ICOG online certificate course on adolescent health, we instruct all the attendants attendance for all 3 days course is compulsory. This is the first point. Then Google link for MCQs will be sent in the chat box. Those who have attended all 3 days course and pass with 50% marks on each day, they only get the certificate from ICOG. Then the certificates will be sent within 1 month. Please note that this online course certificate is just an acknowledgement of attendance. Practice depends on skill and experience, which we do not certify. So we do not endorse any skills of the attendees. The videos will be put on ICOG website in due course. For course material and equipment details, you may communicate with the course coordinators. So we have thanks to Dr. Parag, Dr. Sarita Madam. So thank you very much. And the coordinators we have for day 1, today we have Dr. Poonam Lal, who is actually, she is a senior consultant at Kuchi Holy Family Hospital, Patna since 22 years, DNB teacher since 19 years. She is also the member of Adolescent Health Committee, FOXY, and has worked lots during my tenure. East Zone Coordinator, Aesthetic Committee, IMS. She is doing very good in this cosmetic area also. Secretary, Patna Park. Chairperson, CME Committee, POX. Joint Secretary, IAGBR. Executive Committee members of PMS. And life member of FOXY, IFS, and many other bodies. She is also the recipient of IFS Achiever Award. So I welcome Dr. Poonam for today, day 1. And another 2 days, we have Dr. Supriya Arvari, and day 3, we have got Dr. Radhika. So over to you, Dr. Poonam Lal, to start.
Yeah, sorry to interrupt you, ma'am. Suvarna madam had joined for the.
Okay. So will you for the CV?
Yeah,
Or...
Suvarna, can we have your address, please?
Yes. We welcome you, Suvarna ma'am. You'll have to unmute yourself.
Nilima, unmute kar dena.
Okay, I think now can you hear me?
Yes, yes.
Yeah. Okay. Good afternoon, everyone. And at the outset, I want to really thank Parag, Sarita, Supriya, and the entire team who all are here to begin, about to begin the certificate course on adolescent health. And I think today is the day 1, and I'm a little tied up with some meetings, so I will just join and give my lecture a little later than the scheduled one. And adolescent health is so important. I think most of us are dealing with adolescents in daily practice, and we must understand what their issues are. And the most important, the adolescent health that requires attention is the mental health of adolescents, as well as the burning problem, PCOS, as well as so many other hormonal issues, abnormal uterine bleeding. I think I'm sure all these topics are going to be covered in this 3 days certificate course, which is so very well attended. And I really appreciate the efforts done by the whole team, because unless you work hard, you can't get that kind of fantastic attendance. And each and every the member who comes and attends, they go back very well enriched with the knowledge, and they all appreciate the quality of the program. And I really thank you all for having me here. And I see this program, and it's a fantastic coverage of all aspects of adolescent health. And I wish you all the best. Thank you so much.
Hello. Thank you, madam. Over to Dr. Poonam Lal. Thank you. You could join and we could hear your address, words of encouragement. Thank you so much.
Good evening, everybody. Thank you, Supriya, for your kind introduction. At the outset, I would like to thank ICOG for giving me this wonderful opportunity. Without further ado, now we will start our scientific session. Chairperson of the first session are Dr. Vishali Mane. She is the director of the Mane Hospital, Yatmal, and she is the recipient of Maharashtra Jan.
Excuse me, madam. Thank you. Thank you so much. Let's begin with the session. Sorry to interrupt you.
Our second speaker is Dr. Minal Chitguptkar. And they are now I invite our chairperson to start the session. and introduce the speaker. There's slight change in the program. Our first speaker is Dr. Sampat Kumari, who is going to talk on teenage pregnancy in place of Dr. Supriya Arwari today. So over to you, chairpersons.
Good evening, all. First of all, regards and respect to all the ICOG office bearers and all the participants. And it's again my I'm lucky to introduce and to know about the Sampat Kumari madam, one who is a mentor for all of us, guide and teacher for everybody. For madam, I will just
thank you. We'll go with the session. Projecting the screen.
Yes, Shreya.
Yes, ma'am. Yes, ma'am.
I think her network went off.
Yeah, there is some. I am in Darbhanga. There is some network connection problem.
Sampath, maybe you can switch off your video so that when you are talking, so that there'll be less disturbance.
Yes, Parag. First of all, I should thank Parag once again for starting this certificate course first in person in IOG. Continuously, this is the 8th time we are doing this ICOG certificate course. Today, my topic is teenage pregnancy. Next slide. The teenage pregnancy is continuously increasing. So how we can reduce the teenage pregnancy, and how come, what are all the complications in girls under 50 every year? More
I think network is unstable.
Yes, ma'am.
Yes, ma'am.
Next slide. Hello. Hello.
Yes, ma'am. Yes, you can go ahead.
This slide, ma'am. Hello.
For all the adolescents, we cannot neglect whatever the adolescent. It is our duty. Next slide. As per WHO, adolescents are divided into 3 categories: early, middle, and late adolescence. 10 to 13 years being the spurt of the growth of everything, even including this sector. The late adolescents, they want a distinct identity. These are all the categories where the middle adolescents are always attracted by the opposite sector. Next slide. Active before the 20th birthday. Go for the school counseling. We have to talk about this also. 49 girls get married before 20 years. In the community terrace, 10 to 40
Ma'am is not audible. Hello.
Hello.
Ma'am.
So the complications during if there is an age hospital, that is the Semanjari, continuous count, there is 20% of the teenage pregnancy is there. So it has to be taken care. We will see. Next slide. Next slide. See, whenever the teenage pregnancy happens, what happens? The 20 end up in the abortion, and 14% will end up in the miscarriage. Only 59% will go for the delivery. So the first duty is to prevent pregnancy. What is the etiology of the teenage pregnancy? Why it happens, whether it is rural or urban? Right? Yes, continuously you project. See the causes, the rural or urban. In the rural, main because of the poverty, they want the girl to get married earlier. So the early marriage, because of the poverty, they don't send the girls to the schools. There will be so that is the reason once the school dropouts are there, once they are in the house, they are compelled to get the and poor educational opportunities. They don't have the educational opportunities, and because of that, they have the unemployment and the nuclear families and the abuse. Nowadays, even the early menarche, once the girls attain menarche, the parents they want the girls to get married immediately, and the domestic violences. These are all the causes which poor access to the help. They get married in the adolescent period. How to we have to talk to them about perceptions. On the other side, the incidents of the rape, the alcoholism, the substance abuse, and the social pressures, that is the pressures by the friends, and extreme, the media. So always the adolescents get the information mainly from the friends or the media. The parents should take their up, ask what are all the doubts. If they ask one doubt, they should put a leading questions and clear of the adolescents. To pregnancy, always I used to tell the word the no, whether it is girl or the boy. See the girls, if they were, or when the boy follows him, he should decision to tell no. See, she can tell that I have a lot of commitments. I want to become an whatever it is, engineer or doctor, whatever it is in the schooling. So if she wants, she should take pleasure and pride in saying no whenever. So this is with the girls. And similarly with the boys, even for the boys. So this, the Pinky movie, everyone will be knowing the no means no. So the word no is very, very important for the girls and the boys. The next slide. See, in Tamil Nadu Federation, why I am talking about the counseling itself. If you counsel and make the adolescents to understand complications that can happen in the teenage pregnancy, we can reduce the teenage pregnancy. We always in the from we do the counseling in the in all 21 societies with the permissions of the government. Last month, year, December, we covered almost 3 lakh that everyone should, with the online itself, you can cover in the school days. We should thank COVID for this online classes. They themselves have the link and we did the counseling. Next. So we should make the girls to understand what will happen if even the lactation and the post maternal nutrition. The next slide. The main reason I told is socio-economic deprivation. The poverty, they get married.
Hello, ma'am. Hello. Hello.
Next slide, please.
Ma'am, your voice is interrupting.
Interrupting.
Sometimes it's not audible.
That will happen. Hemoglobin should be 12 grams. If it is not during that period, with that they will get married, and again anemia will be the cause for the complications during the maternal delivery. Now, 50% common cause for maternal mortality. So the complications during antenatal is anemia and increased BP. The girl, and again the BP, the symptoms of the pre-eclampsia and eclampsia will happen. And during the intranatal, the complications being the pelvis is not at all full, not so they may have the because of this they yes, and the girls they will not cooperate. Postpartum hemorrhage because of the non-cooperation, that can be the traumatic fistula also. The postnatal complication being the postpartum illness, that friends will be going to the college and they will be going to the job, but this poor teenage girl will be feeding her baby, and they said they will go for the postpartum cycle. Next slide. Next slide, please. The neonatal, as mother, the complications are the prematurity and low birth weight and intrauterine growth restrictions are. So the mother, since she herself is young, she may not be in a position to take inadequate care and inadequate lactation, which may also in future lead to the neonatal mortality and perinatal mortality. Breastfeeding Next slide. These are all the adolescent pregnancy contributes to the maternal mortality, perinatal mortality, infant mortality, and the same cycle. Here, hello, Poonam, can you hear me? So these are all the statistics about our pregnancy rate of 8 for the adolescent, but still it has to be reduced. Very, very sorry. The incidence is going increased. And the next slide. Next slide. Again, the unsafe abortions. If they become pregnant, they do not know whom to contact for the abortions. They cannot come and tell the parents. So the adolescent should be counseled to go if they become pregnant, where they can go. And depending on the POCSO Act, what we are doing, if the girl comes to us, inform, and then we should help her for the abortions. Otherwise, she will go and have the unsafe.
Hello.
Okay.
Hello.
Poonam, can you hear me? Hello.
Yeah, ma'am. But sometimes voice goes. It is coming and going.
Bandwidth is low, I guess, at
Yeah,
Sampath
I
Ko.
think
Girls
madam's
comment.
network is poor. Network is not so good.
Network issue is there.
Even at my place, I'm facing same problem due to weather.
Slide, please. So the contraceptions, which is
I think you have gone back instead of forward.
Behind. Next slide. Because of the next slide, I want to finish it. So the main thing we have to counsel is about the contraceptions. Next slide. So when we talk with the adolescents, you should talk with the anatomical terms. You cannot tell that don't touch here, don't touch it. Tell them that you cannot touch the private parts, vagina and the breast. So with the anatomical terms, we should counsel the adolescents. The counseling can be given even by the health workers and the mass media in the schools and even the celebrities. If they tell the pure adolescent girl will listen. Next slide. So you can finish. I think, Nilima, you can stop the presentation. So for the adolescent teenage pregnancy, the counseling is very, very important. And you should tell them what are all the complications that can happen and how to prevent. For the school counselings, you talk even about the contraceptions. Nowadays, the progesterone injection, Antara, is available. That can be given to all adolescents. Thank you, Sarita madam. I am very sorry for the poor network. Hope I have covered the important things. Thank you. Thank you, Dr. Sarita and Dr. Parag, for the chance and continuing the course. Thank you.
Thank you, Sampat Kumari madam. Really saying no is a very powerful tool, and I have witnessed your passion for this topic and for the adolescent. I will just say, with this, all the vision which you are bringing, support and empowerment for our teenage. Let's make them informed choices about their reproductive health and well-being by providing access to the education, resources, and support. Thank you once again, ma'am, for enlightening this topic. Thank you.
Poonam ma'am, please go ahead.
Um,
Where
I
is
guess next
Dr.
topic,
Vishal is there?
now we are dealing with the metabolic syndromes in adolescents.
Yes. Dr. Sarita.
Dr. Sarita.
Ah.
Dr.
Hello. Yeah. Can you hear me clearly? Can you hear me clearly?
Yes, ma'am.
Yeah, ma'am.
Okay,
Dr.
great.
Vishali,
So
you
I'm
can
going to
just
start.
introduce Madam. Dr. Vishali?
Yes.
Just introduce Madam.
Yes, ma'am. Please play the slide of CV of
Yeah,
Dr.
there's a
Sarita
slide of
Bhalerao,
sleeve in
madam.
this. Yes.
Just show that. Madam is there. You can introduce her.
Huh.
I think it's okay, Vrishali.
So, Dr. Sarita Bhalerao,
She is the Secretary of ICOG,
yeah,
past President, the Mumbai Obstetrics and
of
Gynec Society,
Indian College
immediate
of
past
Obstetric and
year,
Gynec,
yes,
past president of the Mumbai Obstetric Gynec Society.
Yeah. Thank you very much for that
past
kind
chair of
introduction.
IRC.
Yeah. Thank you very much for that kind introduction. And at the outset, let me thank our conveners and Dr. Parag, of course, for giving me this opportunity to speak to you. Is it clear? Can you see my slides and am I clear? So
Yes.
I'm going to speak on metabolic syndrome in adolescents specifically. And what I'm going to talk about is first the association between adolescent PCOS and the metabolic syndrome, because all of us in practice are very familiar with adolescent PCOS and we are seeing it day in and day out, maybe more and more now in the present. What is the magnitude of the problem? What are the long-term consequences of this metabolic syndrome? How can we help these patients in terms of risk factor screening and treatment? And what can we do as a nation and as a society to help their health? So basically, PCOS, we all know, is a common endocrine disorder. We are beginning to see it more and more in young women. Prevalence in India, studies say, is as high as 10% of women of reproductive age. What do we mean by metabolic syndrome? It includes central obesity, hypertension, and atherogenic dyslipidemia. And if you see my slide on the left, it shows you that what is cardinal to this metabolic syndrome is the insulin resistance. And this insulin resistance, compensatory hyperinsulinemia, is leading to both PCOS as well as metabolic syndrome. Now, what are the metabolic effects of PCOS in the adolescents? PCOS is characterized by hyperandrogenism and anovulation. And way back in 2015, there was Han et al., and he looked at 49 adolescents with PCOS, 40 age and BMI matched controls who didn't have PCOS. And he looked at their biochemical parameters in terms of liver function, cholesterol, LDN, and their 2-hour post glucose load is insulin. And he looked at lean PCOS in one group as well as lean controls also. And he found that overweight obese PCOS and overweight obese control. And what he found is that lean PCOS and overweight obese PCOS both are associated with metabolic abnormalities. And that PCO is an independent risk factor for metabolic syndrome regardless of obesity. So what I'm trying to bring to your notice is that whether your patient is lean or overweight or obese with PCOS, we need to follow them up very carefully to prevent the development of metabolic syndrome. Now, when we look at the association between PCOS and metabolic syndrome in adolescents, we know that adolescents with PCOS have more than 3 times the odds of having metabolic syndrome. And obese adolescents with PCOS also have a high risk of metabolic syndrome than those with obesity but no PCOS. And if you look at their systolic BP even in adolescents will be higher. Their triglycerides are higher. And PCO therefore influences blood pressure and lipid metabolism independent of obesity as early as the adolescent period. Again, high blood pressure and dyslipidemia are the primary risk factors for metabolic syndrome in adolescents with PCOS. And this insulin resistance in PCOS, independently, it causes vascular muscle hypertrophy, interferes with the endothelium dependent vasodilatation, which causes hypertension. It also impairs glucose tolerance. It has adverse effects on lipid metabolism. So, the risk of metabolic syndrome in adolescents with PCOS seems to be comparable with that in adults. And that's a very, very strong statement that Lei Fu et al. Made in 2023. This is, alarming proportions. Now, android obesity is more a risk than gynecoid obesity. Therefore, waist circumference is useful to detect abdominal visceral fat. It is the visceral fat which is metabolically active. And therefore, we must do waist circumference for our patients. If the waist circumference is less than 80 centimeters, it is normal. If it's more than 87 centimeters, there's a significant risk. And tell them that if they reduce their body weight even by 10%, it'll translate to a 30% reduction in visceral fat, which is very, very significant. And this was Adam Balin who said in 2017. So now we come to the next point. What is the magnitude of the problem? And there's this very beautiful article come from AIMS New Delhi, where they looked at almost 20,000 adolescents. Huge study. They looked at school-based, college-based, etc. And they found that the prevalence of the metabolic syndrome in these adolescents was 3.4% in IDF criteria. And if they used other criteria, it was 5%. The prevalence, strangely enough, is higher in our country compared to other countries. Prevalence is higher in urban areas. And they said that the low middle income countries have higher metabolic syndrome among children and adolescents than high income countries. And therefore, there's a tremendous need to intervene in adolescents at this stage for their long term health. These are young people, they have a long way to go. And therefore, they recommend that community based programs, school based programs, public health programs need to include screening, nutritional problems, and non communicable diseases. We have to create awareness at community level for healthy diets with fruits and vegetables. Levels of physical activity need to be increased and limit screen time. And this prevalence of metabolic syndrome in adolescents is a cause of concern because of long term risks of coronary cardiovascular disease, sleep apnea, chronic kidney disease, PCOS, reproductive health, and non alcoholic fatty liver disease as well. So, we come to what are the long term consequences of metabolic syndrome. The risk of coronary heart disease and stroke is doubled, increasing their mortality, fivefold increase in type 2 diabetes, a threefold increase in gestational diabetes, an increased likelihood of endometrial cancer, also a higher risk of pancreatic, postmenopausal breast and colorectal cancer, obstructive sleep apnea, and leading to psychological problems as well. So, what can we do in our clinics? Our risk factors screening and treatment. As for risk factors, some are non-modifiable like genetics, and we know that maternal health during pregnancy affects the health of the child. But what we can do modifiable is the weight, the obesity, the food habits, the screen time, physical activity. And today, because of advancement in modes of transportation, this has become a big risk factor that no people, the children are not walking. Also, eating disorders, substance abuse in young people is more, and identifying anxiety, depression, bulimia, binge eating, body dissatisfaction, and things like alcohol, tobacco, and marijuana, if we can do, will help us to identify these adolescents. Screening is a very, very important thing, and we need to identify these adolescents at risk of metabolic syndrome, their history, physical examination, BMI, and BP. Take a of a history of parental obesity, a maternal history of diabetes or GDM. Look at their liver function tests, screen for type 2 diabetes by a fasting glucose or an HbA1c or an OGTT, and a fasting lipid profile as well for triglycerides. So, our responsibility as gynecologists goes beyond treating menstrual dysfunction and fertility in PCOS patients. We also are their long term caregivers for metabolic syndrome. Lifestyle interventions need to involve the whole family. And the midday meal scheme in India for school children was very helpful because it included rice and wheat and pulses. The school health and wellness program was launched in 2020 under the Ayushman Bharat scheme. And 20 to 60 minutes of moderate or vigorous physical activity daily can actually reverse insulin resistance, and they need to be told this. When we come to pharmacological therapy, we have orlistat, we have inositols, we have metformin, which can be used, and metformin is a time tested drug for many years. GLP-1 analogs are there now for severe adolescent obesity, but there are long term consequences are unclear. And in India, oral semaglutide is available. Now, even tirzepatide is available, but it is reserved only for cases where the benefits outweigh the risks. We don't know the long term things. So I think what we can do is inositols, which increase basal insulin, improve lipid profile, reduce systolic BP. They have no appreciable side effects. And we can consider them for metformin, because metformin, along with reducing their weight, will improve menstrual regularity, reduce the hyperandrogenism, less acne, less hirsutism, weight loss, lower the triglycerides and the LDL. And metformin is generally well tolerated. So I think after lifestyle, the second line therapy can be metformin or metformin combined with inositols as well. What about bariatric surgery? Can result in short-term weight loss in children and adolescents, but it's dangerous. It has to be considered only for those who have completed or almost completed growth in a select group where their BMI is high, they have extreme comorbidities like sleep apnea, non-alcoholic, the liver disease, hypertension, and diabetes. It can be considered. There are now pediatric bariatric centers, and before subjecting anything, we must rule out eating disorders and substance abuse. Otherwise, the benefits will all be wasted. So we come to the last part of my talk, and that is what are the national and the global initiatives. And the government of India is working very hard on this. And increased physical activity, nutritional, well-balanced diets is very much the part of the National Health Mission. And the Rashtriya Kishore Swasthya Karyakram program for adolescents has been doing a lot of work. The Ayushman Bharat scheme for school health and wellness also. There's a national adolescent education program which targets adolescents, and there's a Rajiv Gandhi scheme for the empowerment of adolescent girls. So, all these are basically focusing on a balanced diet, physical activity, taking supplements, and it's along with menstrual hygiene practices and other services. What is Foxy doing? Foxy is very active, and we have a Foxy Adolescent Committee, and we have stalwarts here like Dr. Sampat Kumari, Dr. Supriya Jaiswal. Now, Dr. Supriya Arwari will be taking over. Dr. Parag was also And we have continuously programs on adolescent health. And our president, Dr. Sunita Tandulwarkar, has our flagship program of Teen TK Zindagi Ke for the young and the adolescents. So I think Foxy is also working very hard towards adolescent health, and it will go a long way in improving the health of our adolescents. We have organizations like the PCO Society India, of which I am a committee member, and our founder president, Dr. Duru Shah, is very active in this area. It's a multidisciplinary organization with gynecologists, endocrinologists, nutritionists, dermatologists, and psychiatrists. And the flagship program is the Vijayata program, which is the outreach program aimed at educating women about PCOS with virtual and inpatient awareness sessions. Almost 80 plus sessions have been done. And today there's a paradigm shift from PCOS being an ovarian dysfunction program or a fertility program or a menstrual problem to a multi-systemic, multifactorial problem with significant metabolic consequences. And I really think that at this age, if we are able to reverse it, it will help them in a very big way. We have global organizations like the RCOG and the WHO, which are equipping doctors with emerging skills, with global training programs, and liaison with international organizations like the WHO. And they're creating learning resources, patient awareness material, and really, the objective is that women receive the highest standard of care. So, with that, I thank you all for a patient hearing.
Thank you, Dr. Sarita Bhalerao, madam. Just to wrapping about this discussion of metabolic syndrome in adolescence, the importance of early intervention and prevention is at most important that we come to know, and we can help our young people by developing healthy habits and reduce their risk of chronic diseases later in their life. And not only with this physical illness, but also it will implication for their mental well-being also. Thank you once again, madam, to enlighten on this crucial topic. Thank you, madam.
No.
Next,
Daniel, you can call third speaker.
yeah. Now, okay. Now, next speaker is Dr. Supriya Jaiswal, madam, and she is Vice President of Patna Obstetric and Gynecological Society, Chairperson of Adolescent Health Committee, FOXY 2023-25, Joint Secretary of SOVSI Bihar and Jharkhand Chapter, Chief Consultant, SM Hospital Patna, Executive Member of Central ISOPUB and ISAR Bihar Chapter, also of IAG Patna Chapter, trained in colposcopy, awarded by MPJ John.
Thank you, Akali. Thank you very much.
Welcome, madam.
Thank you. And thank you, and I thank all the ICOG chairperson, Dr. Parag Binewale, Dr. Sarita Bhalerao, madam, and everyone who's given me this opportunity. And I just wanted to share the screen, but if there's any problem, though, you'll have to. I'll request the ICOG team to do the same. Is it okay?
Just sharing.
Is it visible or not?
No, ma'am.
No, ma'am. No, it's not visible.
Oh, I have already shared. So then I think
Ma'am,
I'll have
can
to
I
take
share?
ahead. Once more, just I'm seeing, and if it doesn't come then.
Okay, ma'am. First you open your presentation, then share.
Yeah, actually it was open. I've been doing so many times, no, but no, it is not coming. So I request you to do, Nilima.
Okay, ma'am. Okay. Yes, ma'am.
Thank you. So I start with this topic that is embracing diversity, celebrating LGBTQ identities. Next. So what is the definition? LGBTQ is an acronym that stands for lesbians, gay, bisexual, transgender, and questioning individuals. It represents a diverse community of people with heteronormative sexual orientations or gender identities. Next. You'll have to rush through the slides because it is big. So the prevalence of LGBTQ individuals varies by region and culture. Studies suggest that a significant portion of the population identifies as LGBTQ with estimates ranging from 2% to 10% of the global population. So social status, what does the law says? Laws regarding LGBTQ rights and protections vary widely around the world. While some countries have made significant strides in legalizing some same-sex marriage, protecting LGBTQ individuals from discrimination, and recognizing gender identities, others still have discriminatory laws and policies that marginalize these individuals. Socially, the LGBTQ individuals often face social stigma, discrimination, and prejudice based on their sexual orientation or gender identity. They may experience challenges in accessing healthcare, education, employment, and other services due to social attitudes and biases. Next. So difficulties they face is discrimination is the main thing, violence, mental health issues, homelessness, family rejection, and lack of legal protection. Transgender individuals, in particular, often face unique challenges related to gender affirmation, healthcare access, and social acceptance. So, next. But acceptance of LGBTQ individuals have been increasing in many parts of the world with growing support for their rights, visibility in media and culture, and advocacy efforts. However, acceptance levels vary, and these individuals may still face these discrimination in some communities. Next. So, in the Indian context, LGBTQ individuals have faced a complex social, cultural, and legal landscape that has evolved over time. Traditionally, India had a diverse range of gender and sexual identities reflected in its rich cultural history. However, colonial era laws criminalized these same sex relationships under Section 377 of the Indian Penal Code, contributing to stigma and discrimination against these individuals. So, what happened in a landmark ruling in 2018, the Indian Supreme Court decriminalized consensual same sex relationship, overturning Section 377 and affirming the rights of these individuals. This decision was a significant step forward for LGBTQ rights in India. Despite this legal progress, still these individuals in India still face social stigma, discrimination, and violence. Family rejection is a prime difficulty, workplace discrimination, and lack of access to healthcare services are common challenges faced by these community. So, next. So, in India, activism and advocacy started, and these organizations in India have been instrumental in raising awareness, advocating for equal rights, and providing support services for these individuals. They were such pride events, awareness campaigns, and advocacy efforts have helped foster greater acceptance and visibility for this community. Next. Future outlook, what do we see? The future for LGBTQ individuals in India holds promise with increasing visibility, acceptance, and legal protections. Continued advocacy, education, and community support are crucial in advancing LGBTQ rights and creating a more inclusive society in which all individuals are valued and respected. Next. While progress has been made in advancing LGBTQ rights in India, there is still work to be done to address systemic discrimination and ensure equal rights and opportunities for these individuals across the country. Continued efforts towards social acceptance, legal protection, and access to healthcare, these were done. So, next slide. So we are trying. So the key points to consider is identify formation. That is, adolescence is a time when individuals are exploring their identities, including sexual orientation and gender identity. LGBTQ adolescents may face confusion, fear, and stigma as they come to understand and accept themselves. It's very difficult to understand. Mental health, these are at a higher risk for mental health issues such as depression, anxiety, and suicidal thoughts compared to their heterosexual or cisgender peers. It is essential to provide them with support and access to mental health services. Next. So, creating safe and supportive environments at home, in school, and in the community is crucial for the well being of these adolescents. Supportive adults, inclusive policies, and LGBTQ affirming spaces can make significant difference in their lives. Now, these adolescents are at a higher risk of facing bullying, harassment, and discrimination. It is important to address and combat these negative behaviors to ensure that safety and well-being of these youth. Next. Coming out is a personal and ongoing process for these individuals. It is essential to respect their autonomy and provide a supportive and accepting environment for them to come out on their own terms. Providing these individuals sex education, access to LGBTQ friendly healthcare providers, and resources such as these support groups can help adolescents navigate their identities and experiences. Overall, supporting these adolescents requires creating inclusive and informative environment. By being informed, empathetic, and supportive, we can help these LGBTQ adolescents thrive and reach their full potential. Next. Some of the key challenges is discrimination, as I said, bullying and harassment, family rejection is very painful, mental health issues, lack of supportive resources, intersectional challenges, and legal and policy barriers, religious and cultural factors. So, the mental wellness of these adolescents is some key factors like higher rates of mental health issues, as I already explained. Social isolation is very painful, may experience social isolation, loneliness, and a lack of support from peers, family, and community members because they look down upon them. This can lead to feelings of alienation and disconnection, which can negatively impact their mental health. Next. So, bullying and harassment, we already explained. Family rejection is beyond, this leads to depression and anxiety. Supportive family relationships are essential for the well being of these youth. LGBTQ adolescents may internalize the stigma and discrimination they face, lead to feelings of shame, self doubt, and low self worth. This internalization stigma can impact their mental health and contribute to negative outcomes. Next. So access to support system, we need to have them mental health services, support groups, and resources. It is important to provide access to culturally competent and inclusive support for these youth. Then they belong to this, we have already explained that despite the challenges they face, many LGBTQ adolescents demonstrate resilience, strength, and creativity in navigating their identities and experiences. It is important to recognize and celebrate their strengths and empower them to thrive. Next. So there are certain rights. Over the years, there have been significant legal developments regarding LGBTQ rights around the world. Here are some key points regarding their laws and outcomes. Many countries have decriminalized homosexuality over the years. There are still some countries where homosexuality is illegal and can be punished by law. Then, in several countries, same sex marriage has been legalized, granting LGBTQ individuals the right to marry and enjoy the legal benefits that come with marriage. This has been a significant milestone in the fight for their rights. Next. Anti-discriminating laws are there, where this housing and public accommodations, adoption and parenting rights is very important. Here, the couples have gained the right to adopt children and have parental rights in many jurisdictions. However, there are still places where restrictions exist. Healthcare rights also, laws have been enacted to ensure that LGBTQ individuals have equal access to healthcare services without facing discrimination. Then hate crime laws. Some countries have specific laws that enhance penalty for crimes committed on the basis of person's sexual orientation or gender identity. Next. So some countries have made it easier for individuals to legally change their gender marker or on official documents to align with their gender identity. Conversion therapy bans all their challenges and ongoing issues that despite progress, LGBTQ individuals still face challenges such as discrimination, violence, and lack of legal protection in many parts of the world. So advocacy groups continue to work towards achieving fully equality, and protection for these individuals. Next. So now supporting them, these individuals in achieving their rights and fostering a more inclusive society involving collective efforts at both the individual and societal levels. So how do we do that? Is education and awareness is important, advocacy and support, creating safe spaces to live, respect and affirmation, legal protection, and healthcare access. By taking these action, individuals and society can contribute to create a more equitable, inclusive, and supportive environment for LGBTQ individuals, help them achieve their rights and fully acceptance in the society. Next. Role of media is very much visibility and representation is through media is very important for them. Next. Impact on attitudes, like media portrayals of LGBTQ individuals can influence public attitudes, because positive, if you project them positively, it will really help. Then inclusive media representation can contribute to the normalization of these individuals. So next, so I'll have to rush because I think there's 3 minutes left. And challenges and stereotypes are there, authenticity and diversity, like embracing intersectionality and showcasing the diversity within the LGBTQ individual community can help create more compelling and accurate representations. Next. Media advocacy, already explained, progress and challenges. While there have been positive strides in this representation in recent years, there is still a need for greater diversity, inclusion, and storytelling in the media. Continued advocacy will really help. Next. By promoting authentic, respectful, and inclusive portrayals of these individuals in the media, we can contribute to a more equitable, understanding, and accepting society for all. Next. So these are the rights and movements. It is in detail, but we can just go through that. Legislation and policies should be favoring them. Next, visibility and representation everywhere, challenges and backlashes. Reports of rollbacks should be there, international events and celebrations on these people, intersectionality and inclusivity. Then technical and social media, as I said, online advocacy efforts, digital storytelling, and virtual events to connect, and engage LGBTQ individuals globally will help them. Next. Advocacy for LGBTQ rights is crucial for advancing equality, promoting acceptance, and combating discrimination faced by these individuals. Next. So finally, advocacy for this is raise awareness, policy advocacy, legal support, community building. Next. Allyship, media advocacy, healthcare access, youth advocacy. Next. Coalition building, policy research and analysis by engaging in advocacy efforts at various levels, from grassroots community organizing to policy advocacy and international activism. Individuals and organizations can contribute to creating a more inclusive, accepting, and equitable society for these LGBTQ individuals. So the take-home message is promote acceptance and inclusion, provide safe spaces for these individuals, then offer mental health support. That is very important, because we need to get them mentally secure, educate and raise awareness. Education is key to many success. Next. Addressing bullying and harassment, supportive family environment is also one of the major issues where you really need to accept. The family needs to understand, empower LGBTQ youth, encourage LGBTQ adolescents to advocate for themselves, build resilience, and access resources that support their mental health and well-being. Next. Intersectional approach, celebrate diversity. You should celebrate the diversity of these individuals and experiences and promote a positive and affirmative narrative section. So advocate. So next slide. So thank you. This is a very difficult topic, equality for the LGBTQ individuals in India and across the globe. It is very difficult to accept, but then the work is going on, and we see a world where it will come true. Thank you very much for the patient listening. Thank you.
Hello.
Yes.
Where are chairpersons? Dr. Vishali,
Meenal is there.
Minal, Dr. Minal.
You'll
You
have
are
to
muted.
unmute yourself.
Unmute yourself.
Yes, I can hear you now. It was not getting unmuted.
Yeah.
It was amazing presentation about LGBTQ, and even Sampath Kumari madam has given us a very insightful awareness about her lecture also. And thank you so much.
Thank you. So, Dr. Poonam, you can move to the next.
Yeah. So after listening so much, such a enlightening talks by all the STEM speakers, now we move forward for the second session. And chairperson for the second session is Dr. Vidya Thobi, who is the professor and former head department of obstetrics and gynae, AMC Vijayapur. And she is the vice president elect Foxy 2025, president KSOGA 2023, chairperson Food, Drug and Medical Surgical Equipment Committee Foxy 2018-2020, Best Committee Foxy Award she has received in 2020, and ICOG Governing Council member from 2023 to 25. Madam, are you available, ma'am? And now our second speaker is Dr. Bharti Rajsekhar. She is the president-elect KSOGA 2023 to 2024, KPMEA State Vice President, Indian Red Cross.
Dr. Poonam, I think you need to read the whole thing.
Yeah.
It's fine. I am the Foxy Perinatology Chair. This is an old CV of mine.
Okay, okay, ma'am.
It's okay. Thank you.
Our third chairperson is Dr. Manisha Barmade. So I request our chairpersons to introduce the speaker and introduce their topic. Thank you.
Thank you. At the outset, I would like to congratulate Dr. Parag and the entire ICOG team for putting up this excellent program of adolescent health certification course, because as we all know, the health of the adolescents will reflect on the health of the nation as well as the progress of the nation. The previous session, we had very good sessions on teenage pregnancy, which is quite rampant nowadays, as well as LGBTQ, which is a necessity that we all need to include them in the society and be very proactive with them. And Dr. Sarita Balerao spoke about the metabolic syndromes in adolescents. So this session, we will be talking about two ends of one spectrum, that is primary amenorrhea by Dr. Suvarna Kadilkar, the precocious puberty by Niharika Allu, and how to set up an adolescent clinic, because we need space, we need confidentiality. These adolescents have to be very comfortable when they come to us, and that Dr. Priya Vora will be elaborating. And we have Dr. Patanjali Dev Nair, who will be speaking on adolescent sexuality and mental health. I think, if I'm not mistaken, the first speaker is going to be Dr. Niharika or Dr. Suvarna. Do I need to introduce Dr. Niharika, Dr. Poonam?
Yes, Niharika, ma'am.
Fine, fine. Well, Dr. Niharika is a very young, dynamic Foxian and ICOGian and a close friend of mine. She is a consultant obstetrician and gynecologist at Rainbow Hospital, Visakhapatnam. Right, she's been the secretary of ISAC Society. She's a national faculty for HPV vaccination, as well as she's received awards for the Nana Anemia Program and the Master Trainer of HPV Project. She's been the executive committee of Vaginal Surgeries Committee, as well as cell members and member of the cell and publication of the publication cell. So over to you, Dr. Niharika, who will be speaking about precocious puberty, which is quite a perplexing and an intriguing problem when we need to address these issues. And it is quite a scary situation for those parents who come to us with these young children with precocious puberty. Over to you, Dr. Niharika.
Thank you, Dr. Bharti, Dr. Vidya, and Dr. Manisha. At the outset, I would like to thank Dr. Parag, Dr. Sunita, Dr. Supriya, and Dr. Sampath ma'am for this wonderful opportunity to talk among such big people in the ICOG. So the topic given to me is precocious puberty. So before we proceed, and talk about precocious puberty, I think it's very important for us to understand that what are the different stages of puberty itself so that we can figure out what is abnormal. So we all know that puberty is a complex developmental process, and it is the maturation of the hypothalamo-pituitary ovarian axis which actually causes the puberty. So we have the appearance of secondary sexual characters and acceleration of growth, and it tells a woman's ability to be fertile. So as you can see, the HPO axis is actually active after birth, and then it becomes quiescent till it reaches the puberty. And at puberty, this HPO axis gets activated. So there is an increase in the pulsatile GnRH, and this in turn causes an increase in the FSH and LH, initially in the sleep, and then over throughout the 24 hours, this increase occurs, and which acts on the ovary to produce the estrogen and progesterone. So this is how a normal puberty functions. We all know this, it's just a refresher for us. So puberty usually commences from the age of 10 years and it lasts anywhere between 3 to 4 years, and every stage goes through approximately 1 year of age. The first sign of puberty is usually a breast budding or a thelak, wherein the Tanner staging is stage 2. And the next thing that happens is the development of pubic hair, that is the pubarch, and then the axillary hair. Onset of the growth spurt, that the growth velocity that we see in children, occurs along with the breast budding, with the peak height velocity happening at the mid-puberty. The menarche is usually occurring within 2 to 3 years of the advancement of thelak. So as you can see here, we use the Tanner staging to stage the thelak and the pubarch, and usually the stage 5 in the thelak is considered as an adult stage, whereas anything from stage 3 onwards is considered an adult stage when it comes to the pubic hair. So let us delve into the topic that is given today. As Dr. Bharti was saying, precocious puberty is something that is very common now. I see a lot of kids coming at, say, third class, second class with, menarche and changes of the secondary sexual character. So how do we define it? So usually the definition is that appearance of secondary sexual characters before the age of 8 years is called as a precocious puberty. So this should alert us that this is not normal and this probably needs an investigation. So the incidence is anywhere between 1 in 5,000 to 1 in 10,000. And we all know that having a precocious puberty is not only a problem for the parents, but also has a psychological impact for the child, because of the body changes compared to their peers, they are expected to behave as per their physical whatever she's looking like, instead of the chronological age, wherein she's a smaller child who's just 8 years old, but she's looking like an older child, and he is expected to behave like one. So there's a lot of psychological problems associated with it. And in addition to that, they also experience accelerated bone maturation, which causes a premature epiphyseal fusion, and this will actually eventually compromise their final height. So this, you can see the graph here. This is a graph of a girl who's had a precocious puberty. So as you can see, there is accelerated bone maturation, but eventually the final height is much lesser than expected. So how do we classify the precocious puberty? So we have a gonadotropin dependent central precocious puberty, and we have a peripheral, which is gonadotropin independent precocious puberty. We also have variants of premature sexual development, and I feel a lot of times these are the things that we actually see in the day-to-day basis, because the incidence is 1 in 5,000. So it's very rare for us to actually come across a central precocious puberty so commonly. So we have an isolated premature thelak where only the breast budding is seen. And we have isolated premature pubarch where you see only the pubic hair or the axillary hair isolatedly, or you have an isolated premature menarche. So we can also classify based on the secondary sexual characters. So if the secondary sexual characteristics are appropriate for the sex, that is, they look like a female a pattern, then it is isosexual. It can sometimes also be a heterosexual or a contrasexual where they are contrary to the female phenotypic pattern. That is, if it is virilization in the girls. So central precocious puberty is almost always isosexual, whereas the peripheral precocious puberty can be either isosexual or heterosexual. So ideal scenario is that whenever we come across a precocious puberty child, ideally we should investigate it and treat it by a pediatric endocrinologist. But we all know that in the regular scenario, these kids are usually brought to us as a gynecologist because the mother is concerned. She may have been your patient, or she may have been referred to the pediatrician who sits next door to you, and you are frankly the first person who actually gets to see these kids. So even though initial assessment, there is no role for gynecologists, and the role is majorly to rule out any local pathology and to do an examination under anesthesia, where you may be looking for some cause of vaginal bleeding like a foreign body, or to rule out sexual abuse. I would say that all of us actually experience seeing a precocious puberty more than we are supposed to. So we should know how to evaluate by history, examination, and what are the basic investigations. And I am here to take you through these today. So when you take a history, you should always ask for what is the age of onset, what is the sequence and progression of the pubertal changes. And that is why we needed to know what is the normal pubertal changes that occur in a female. And also sometimes there can be a family history of similar things in the mother or the siblings. We may also need to take history which may suggest us that there may be a neurological cause. It is very important to also ensure that we take history for any exogenous sex steroid exposure in terms of food, drugs, or even cosmetics. Food especially, because nowadays I think all of us must have read that the chicken is being given hormonal injections so that they mature faster and they have more sale. So this is being consumed by the kids. A lot of kids love non-vegetarian food in different forms, and this steroid hormone exposure is happening even in the form of something as simple as food, and this could be the reason why the precocious puberty is on the rise. When we look at the examination, it's always good to use age-specific growth charts to measure the height and weight ratio and take a BMI, and always use the Tanner staging to identify the thelarch and the pubarch. And if the history suggests that there may be a neurological cause, it is important to do a neurological examination of the eyes, which may include a visual field or a fundoscopy. Also look for skin lesions, which may point out to you cafe au lait spots. If they are there, it may point out to a neurological pathology. And always do an examination of the abdomen, which may tell you that there may be some tumors. Examination of the external genitalia is equally important because sometimes we may pick up signs of virilization like clitoromegaly and hirsutism. If we have a patient who's coming to us at the prepubertal age with vaginal bleeding, as I said, very important to rule out exogenous administration of estrogen, also rule out vulvovaginitis, any foreign body trauma, urethral prolapse, and definitely a sexual abuse, which is very common these days. Also consider a rectal bleed. Think of an examination under anesthesia when you have a heavy vaginal bleeding or you're suspecting vaginal trauma, a tumor, or a foreign body, or when bleeding is continuing despite negative findings on the examination. Always do a full blood count, genital swabs if you're suspecting a sexual abuse, pelvic ultrasound if your examination is incomplete, and urine analysis to rule out urine infection, because sometimes the kids may be confused as to where the blood is coming from. So once we have ruled out these basic things and we suspect that this could definitely be a precocious puberty, it is best to do a baseline serum LH and FSH level, and then go on to do something called as a GnRH stimulation test, about which I'll be telling you in the next slide. Also do an estradiol and testosterone levels, and we can consider doing 17-hydroxyprogesterone and DHEAS if we are suspecting CAH or adrenal tumors. And serum prolactin may be raised in chronic hypothyroidism, McCune-Albert syndrome, or some prolactinomas. TSH and free thyroxine are also an essential in this. Again, next thing that we should do is a left wrist X-ray for assessing the bone age. Sometimes the bone age may be more than the chronological age. This will tell us that there is definitely some steroid or hormonal play that is happening. And we should do a CT or an MRI or CT of the adrenals if we are suspecting a specific cause. Pelvic ultrasound can be done on a regular basis to assess the size, shape of the uterus, and look at the endometrial thickness to see if there is any echo, and also rule out any ovarian pathology or any ovarian tumors. So let us see what is a GnRH stimulation test. So to diagnose central precocious puberty, this is the gold standard. So this is basically performed by sequentially measuring the FSH and LH levels after giving a bolus of GnRH analog. And if it is a healthy puberty, or even if it's a precocious puberty, the LH predominance will be there. That means the LH to FSH ratio will be more than 1. Whereas in a pre-puberty, the LH will be less than the FSH. The FSH response is more than the LH response. The values more than 8 are usually taken as diagnostic of CPP. In CPP, the bone age is advanced, often by more than 2 years, and you actually have an endometrial echo or a pear-shaped uterus with a uterine volume of more than 2, and the baseline gonadotropins are generally raised. And this is because of premature activation of the HPO axis, and this gives you a very similar picture to a normal puberty. And almost 74% of these are idiopathic, where you will not find a cause. But there may be some causes like hypothalamic hamartomas, any tumors, some congenital disorders, acquired infections or irradiations or post-head traumas, chemotherapies, and also something which is secondary to a peripheral precocious puberty. The goal here is to halt or cause regression of these changes and to prevent the early menarche and retard the skeletal maturation and improve the final height. So GnRH is the mainstay of treatment here, and the efficacy of GnRH is best if it's given below 6 years with regards to the height. But if you are using this beyond 8 years of age, it may not improve the final height, and there may be a modest improvement in the final height in girls who are between 6 to 8 years. So the response is usually monitored by growth, anthropometric measurements, by assessing how the puberty is progressing, and bone age at regular intervals. And usually this treatment is stopped when it is time for a normal puberty to begin, and adult bone mineral density is generally not affected by this childhood GnRH therapy. When it comes to peripheral precocious puberty, it's usually because of the various reasons. So the features are dependent on the etiology, but you will generally see a rapid growth, advanced bone age, and you may see clitoromegaly or pubic and axillary hair. So you will see isosexual or heterosexual features also. So the causes can be anywhere from an ovarian tumor or adrenal causes like CAH, Cushing's, or neoplasms of the adrenal gland, or exogenous sex hormones, McCune-Albert syndrome, and severe long-standing hypothyroidism. So if it is hypothyroidism, we can treat it with replacement of thyroxine. And if it is any exogenous source, you discontinue that and treat CAH. And if it is secondary CPP, you can also use a GnRH agonist therapy. So here you can see the difference between this CPP and the peripheral precocious puberty, where the pubertal response is different, and that is how you can differentiate. And also you will see an endometrial echo separately. The commoner ones that we would generally see is the premature thelar, where the bone age will be normal and the baseline gonadotropins and the GnRH test will be more like a pre-puberty, and ultrasound will be normal. So this is generally a self-limiting one. Usually it is seen below 2 years of age, and the final height is usually good. Whereas premature menarche, again, you will have pre-pubertal ultrasound picture with no endometrial echo. So this also usually tends to resolve in 1 to 2 years of age. So all you need to do is follow up. Similarly, premature adrenarche may be there, where the bone age may be advanced, and this can be a forerunner for PCOS. So these children should always be under follow-up. So this is the final slide where you can actually follow this flow chart whenever you have a child with a premature sexual development, where you can assess the growth age, you can do the bone assess the growth velocity, then do the bone age and divide based on your pubertal or prepubertal response to your GnRH, and then do the investigations as per your need. So thanks a lot for your patient hearing.
Dr. Niharika, I think that was a very clear and crisp message, very wonderfully presented with the grand finale of the algorithm. I think if we have this on our desk, it makes it very easy for us to point out whether it is a peripheral cause, if it's any other tumors or organic causes there, or is it just a problem due to an idiopathic cause. And I just would like to comment here. Do you think the lifestyle and the use of refined and processed food and the lack of activity is one of the causes for the increased incidence of PCOS?
Definitely, ma'am, because I think
of precocious puberty, sorry.
Yeah, definitely obesity, ma'am, because I think you need a minimum of 40 to 45 kgs for menarche to happen. So I think lot of children are getting to that weight much earlier. I think I was probably 50 kilograms in my 12th standard.
Yes.
So I see second standard, third standard kids being 50 these days. So no wonder that they are all having precocious puberty. Yes.
Yeah.
Madam,
Thank you so much.
Dr. Vidya Tobi and
Madam Bharti ma'am, I would like to make one comment here. There is a study that has shown, proven beyond doubt, that because of excess exposure to screen time, they are getting precocious puberty.
Yes.
Because of the continuous bombardment of the audiovisual inputs, the pubertal axis is maturing faster, and girls and boys are getting premature or rather precocious puberty. That's they have 2 year study post COVID they have conducted, and there are figures pointing to that. It's really shocking and something that is beyond our control, I feel now.
I think we have to control. We have to start somewhere and try to put an end to it. I request the other co-chairpersons, Dr. Manisha is there and Dr. Vidya Tobi, to take over the session.
Thank you, Sam. Thank you so much for this opportunity, ma'am.
Hello. Hello, madam. Thank you. It's very good talk by Dr. Niharika. I would like to invite Dr. Priya Vora, ma'am, who is a OBGYN consultant and IVF specialist at Vora Hospital in Mumbai. She has training diploma in reproductive medicine, IVF in Germany, certificate course in ART. She also held leadership role in the reproductive medicine and research department at Nauroji Wadia Hospital. So, madam will enlighten on how to set up the adolescent clinic. Over to you, ma'am.
Yeah, I need to share my screen. So tell them to give me the permission.
Yes, ma'am. You can share. Yes, ma'am. Make it. Yeah. Start. Go ahead.
Is it visible?
Yes.
Yes.
Okay.
Yes, ma'am.
Yes, ma'am.
Yeah, so I think I'll quickly run through these initial slides, which talks about the definition of adolescence, which is a transitional stage of physical and mental development, which occurs between childhood and adulthood. This transition, it involves biological, social, and psychological changes. We all know the stages of adolescence, where adolescent is between 10 to 19 years, the youth is from 15 to 24, and young people between 10 to 24 years. And why do we need to really give importance to the adolescent health? Because they represent a positive force in society in the now and in the future, and we have a greater understanding of their biological, psychosocial, and physical vulnerability. At 8.24 billion young population, if you see, about 21 to 23% is between the age group of 10 to 24 years. And 90% of the adolescent, they live in the developing countries. 1/3 of disease burden in the adults is related to events at adolescence, and 2/3 of them, even the premature deaths, could be related with this group. And road accidents also and suicides are a leading cause of deaths in these. Why should we talk about the adolescent health? They face dangers which are more complex than previous generations which they face, and they have less support. Early puberty, nuclear families, effect on the mass media, academic pressures, a rat race, explosion of technology, urbanization, industrialization, globalization, experimentation with internet and mobile phones all plays a role in this group. Injecting the drugs, when they try to inject them with the drugs, there's always a risk with the sharing of the needles. In India also, we see that 22.8% of the Indian population, so they contribute to around almost this large part of our population, where 47% are the girls, more than 30% are sexually active, 45 are the girls, and 20% of the boys are stunted. If you see, 50% of them are married by age of 18. 50% of all new cases of AIDS less than 25 years, and 50% of HIV positive cases are females. Rise of incidents of violence, road accidents and suicides also has increased. There's a lot of unhealthy habits also, and if we are seeing that one at least in every 6 of the adolescent, they are overweight, they have diabetes, they have cholesterol, 1 in 3 teens have bad eyesight, and 1 in 5 has stress related emotional disorders. The rights of adolescent, each and every of them do have the survival right, developmental rights, protection right, and participation rights. And all these rights have been enshrined in the international legal documents, and each of them do deserve this. Now, according to the WHO, when we invest in the adolescent health, it is a triple benefit to us, because we are having the healthy adolescents now, healthy adults in the future, and a healthy future generation also. However, there are certain barriers which are there for healthcare. Lack of knowledge on the part of the youth. There is legal and cultural restrictions, physical or logistical restrictions, poor quality of services, unwelcoming services, a high cost, barriers, peer pressure, and a fear of disclosure. The aims at Yuva Clinic, which is an ideal Yuva clinic, it should provide access to nutritious and healthy food, promoting mental well-being, promoting sexual and reproductive health, reducing use and minimizing harm from substance abuse, promoting safe environment, improving the healthcare seeking behavior, promoting good physical activity also, and nutritious food. What are the aims of adolescent friendly health care services? That is to reduce the death and disease in the adolescent now, to reduce the burden of disease and later on in life, to invest in health today and tomorrow, to deliver on the human rights, especially the reproductive health care, and to promote to protect the human capital. Now, this is the national standards which should be there for the adolescent friendly services. We have to have a separate consultation room, separate consulting time, informal and educational pamphlets are displayed and made available to the adolescent and youth to take away, maintain privacy, and provide enough consulting time. And also we need to maintain and develop standard history taking protocols, physical examination protocols, case records need to be maintained, develop standard treatment protocols, and develop an adolescent health card which should remain with the client. The youth friendly services which are there, they should be promotive, preventive, curative, referral, outreach, and informative. Promotive, where your focused care is given in the antenatal period. Counseling and provision for emergency contraceptive pills. Counseling and provision for reversible contraceptives. Information regarding the sexual health and reproductive health. Preventive services like services for immunization, services for prophylaxis against nutritional anemia, nutrition counseling, services for early and safe termination of pregnancy, and management of post-abortion complications. The curative services which are important, that is treatment and counseling for the menstrual disorders also, and common this reproductive tract infections, treatment and counseling for sexual concerns of male and female adolescent, management of sexual abuse amongst the girls, referral that is voluntary counseling and testing center, prevention of parent to child transmission, outreach, that is periodic health checkups and community camps, and periodic health education activities and co-curricular activities. What are the characteristics of friendly services? An attitude of respect for the client, irrespective of the age or socio-economic or gender bias or marital status. A friendly approach, assuring of confidentiality, accessible location and a friendly atmosphere, practicality of the working hours, and affordable services should be provided. There should be adequate staff. We need to have multi-speciality team, trained doctors, develop a network of adolescent-friendly experts in the clinical specialties, and promote education and camps in communities, schools, teachers and parents, youth clubs and youth centers and associations, and monitoring of the services by maintenance of the records of the adolescent, also self-assessment and periodic assessment to ensure that the standard guidelines are followed in the Yuva clinic. These are the various locations where it could be at the various hospitals, or it could be with the NGOs, or it could be run with the community centers, outreach services, and various workplaces also. Now the FOXY recommendations where allot specific time days for separate working area, consider consultation both by appointment or walk-in basis, ensure confidentiality and privacy, display signboards stating the time, the services and the cost, ensure clean toilets, safe drinking water, necessary equipment should be present, and information education material should be available. Now decide also the service packages, develop standard clinical procedures, then strengthen the skills of the staff, outreach activities for demand generation, and monitor performance of the clinic. Now the Adolescent Health Committee FOXY, this is the case record, which is the pro forma which is followed, where all the preliminary, the details of the adolescent are written. However, the items 3 to 6, it's optional. And in case they do not want to disclose their identity, then the registration number, it can be even done only given. And then the examination findings, the history, the systemic examination, the various investigations which are provided, the interventions, that is nutritional counseling if it's done, counseling for exercise and physical fitness, anticipatory health guidance, that is injury prevention or substance abuse, responsible sexual behavior or immunization. So all this is mentioned in detail. Referral and even follow-up visits have to be documented. Now, a suggested protocol for the annual periodic checkup of a Yuva clinic, that is the physical checkup where you can see that the height, the weight, the Tanner staging, the BMI, the blood pressure, visual checkup, hearing assessment, dental checkup, and developmental stroke behavioral screening. The head screening has to be done. Then counseling and anticipatory guidance if it's done regarding for the normal development, the nutrition, then injury prevention, physical activity, safe sexual behavior for older adolescent. Then the sexual character, the development is also assessed. Substance abuse, including tobacco and alcohol, or life skills where promote self-esteem, communication skills, coping with emotions and stress, and negotiation and assertive skills, and decision-making skill. Take-home message: take young people seriously. We need to offer them help quickly, give attention and encouragement. Don't offer false assurance. Encourage them to talk it out. Help them to understand the cause of distress. Maintain continued contact. Focus on positive behavioral and expect the rebuffs. Emotions of a youth can be positive, like feeling happy, loving, confident, inspired, cheerful, interested, grateful. And it also can be negative, like feeling angry, resentful, feeling ashamed, guilty, sad, or worried. So we need to really be very supportive. And these are the references which I have taken my slides from. And I would like to thank you all for a very patient hearing.
Thank you, ma'am, for very enlightening and stimulating presentation. Adolescent population need to handle their issues with tender care. Communication is the only way to handle, and it is a group practice. We should be involved psychiatrists, gynecologists for to deal their issues. Very nice, ma'am. Thank you very much, ma'am, for good presentation.
Thank you. I would like to thank the organizers, the chairpersons for this opportunity.
Hello.
I would like
Is Dr. Vidya Tobi there? Dr. Puram, is Dr. Vidya Tobi there?
I could
I
not
think she's
see.
not there. I don't see her here.
Then Manisha can.
Yes, we can go ahead with the next speaker introduction.
Madam, you can.
Okay, fine. So Dr. Patanjali is going to speak next, right? Yes. It is indeed an honor and privilege for me to introduce Dr. Patanjali Dev Nair, who has held various positions in the W Health Organization as a technical officer of maternal, child, and adolescent health in Manila, Philippines. And he's been in other countries like China, Hong Kong, Malaysia, Philippines, Mongolia, and Vietnam. He's been the technical advisor for UNFPA India, which is regarding adolescent reproductive and sexual health program development, implementation, and monitoring and technical support from 2006 to 2007. He's been an ST professional of the World Health Organization and has been a program implementation and support for 11 countries, which have been initiatives in India, Indonesia, Nepal, and Thailand. He's been the Directorate of Education, GNCT, New Delhi, as the chairman and project director of the YUVA program, which is a very, very successful program going on in schools for children and adolescents. He's been heading the HIV and AIDS unit in the WHO, and he has developed integrated and focused HIV/AIDS interventions in young people. He's also the counselor, columnist, health educationist, a TV anchor, and regularly wrote a weekly newspaper in the Indian Express for more than 5 years, and a UNFPA helpline, web-based counseling developed scripts for, and he has hosted more than 200 TV programs on health in India. I think that is what we all need to follow, that creating more and more awareness on adolescent health and sexuality, which Dr. Patanjali Nair is going to speak on, because with the overlapping of the MTP Act, the POXO Act, and the PCPNDT Act, I think there's a lot of confusion about adolescent mental health and sexuality, and more with the exposure to social media and access to various methods of sexuality. The adolescents are in a confused state. Parents are fearing to send their children out, and I think Dr. Dev Nair will be able to elaborate and give us the guidelines and how to manage such issues. Over to you, Dr. Patanjali Nair.
Thank you so much, ma'am.
Yeah,
Can I have a co-host?
sorry to interrupt you, ma'am.
Yes.
Suvarna madam is waiting for her lecture. If you introduce, she will take this lecture.
Is it okay? We have introduced Dr. Patanjali sir already. Could you just ask
It's
her?
okay. I think he has already started. I don't want to disturb you.
Thank you,
It's
madam.
okay. You can finish. I'll take afterwards.
Thank you. Thank you, Dr. Suvarna. Thank you very much. Over to you, Dr. Patanjali.
Yes, ma'am. Yes, ma'am. I'm just trying to. I was told, stop here. Okay. Is it now full screen? No, not yet.
Not yet full screen.
Yeah, okay. That's
Yes,
come
now
now?
it is. Now it is, Dr. Nair.
First of all, I have to thank you, ma'am, Dr. Bharati. You very patiently read out some of the points, a few points which I had written on one slide. The
Interesting, and I
idea
want
was to introduce to the
everybody to know about
gynecologist. Yeah, the idea was to introduce to the gynecologist that a non-gynecologist or even a non-pediatrician, I'm a public health person and an ophthalmologist by training. What is he doing in adolescent health? And perhaps spoke about it a bit earlier. That's fine. I want to thank Supriya ji, who has brought me in, and of course Dr. Das also was wanting. And most of all, your president, and then Parag, a dear friend, a passionate person here. I know I've taken a minute of my precious time to do it. But unless you link people and who are doing a good job, and bring them forwards, talk about them, talk about an association like Foxy, which is working for Adolescent, that has been my dream, and when we started it around 25 years ago, we just didn't have anybody ready to talk about it. I had to appear in front of 2 parliamentary committees to explain why are you spoiling the morals of the young girls and boys by talking about sex education to them. That was the situation. And today, 5, 7 years ago, we have a Kishoravastha health program in India. So that's how it changes, things move. And all that has happened is because of good people like you who have done it quietly. Now, nobody talks about it. This session is deliberately named Sexuality and the Mental Health. The reason is whether it's adolescent pregnancy, abortions, HIV, STD, whatever you name, starts with sex. But sex is not sexuality. Sex is just one part of very minimum part of sexuality itself. And it is a central aspect. That is a definition, as you can see from WHO website. It's a central aspect. First thing you have to remember that all humans, or in fact all animals, are sexual in nature by birth. So day one child is also has a certain amount of sexuality in her or him. That's fine. So and human throughout the encompasses sex, gender, sexual orientation, erotism. Nowhere does WHO condemn erotism. Pornography is very different from erotism. Pleasure, because it's a pleasurable thing. That's what intimacy, emotional and physical intimacy, and of course, reproduction. I have deliberately added more material in every slide so that can become a reference one. I will not be insulting you all by reading every word or line of it. It's not needed. What is needed, certain points, and we can deliberate further on. So the extra material and references are for you all. There's a connect. That's the first, rather the second slide coming up. There's a huge connect, and this book, which I've shown on Brook, you all can access it even on the internet, Google, you can find about it. WHO defines sexual health we have talked about. There are 3 areas of sexual health that intersect. That is low, left side low given. Poor sexual health on the part of those who have poor mental health. We all know that. You just see how much a burden the gynecologist may be having because of poor mental health, that they come with poor sexual health and poor reproductive health and poor gynae or obstetric health, including the early pregnancy. Wonderful lectures. Parag, I want to thank you. My own gynecology is being revised, which I loved earlier, so I'm so happy. But you see that unless we realize that some of those things which we see as gynecological problems are actually mental health problems, and we are unable to deal with them because we haven't got the connect with us. So that's the point. And this session of 15 minutes will be just introducing some of the topics and some of the points we'll need to have deeper, and all of you who are interested can study deeper. Gender identity and sexuality, as people spoke about the gender, I think it was Supriya ji who talked about a lot about it, and LGBTQ, sexual abuse. I think 2 or 3 speakers have spoken about it. I think Niharika and even Priya Voraji have talked about it, domestic violence and harassment. So you see, there's a huge amount of literature review, and one of the most important protective factor is healthy relationships. Now that's where the gynecologist can play a big role to encourage children, adolescent, adults, all of them, men and women both. I was very happy when Priya mentioned in the adolescent friendly healthy retreat as for girls and for boys. I was wondering, they'll be coming to you also. This is one of the slides due to puberty. We talked a lot about puberty, but the sexual aspect is usually missed out. We see the physical aspects or sometimes in the mental cognitive aspect. What about sex? What about his or her desires? What about his or her playing out those desires when they neither have the skills, nor the aptitude, nor the information about it, and but they play out because they're adolescents. They tend to explore and they grow up in ambience. See these images. I'm sure, I like to be explicit here. We are all scientists. There's a nature, day-to-day life, literature, religious symbolism, language, jokes, interest objects. We all crack jokes. You see dogs mating, dogs and the bitch mating on the street, common thing. A lot of people in the villages, actually adolescent, help deliver the cows and the goats to that. So it's a common phenomena for them. It isn't something hidden, and they apply it to themselves also. I mentioned to, I think, Ms. Vora or the earlier one, that there is a orientation program for the adolescent. And just to, I picked up this slide to actually to tell you that spectrum is very big. So it's not that we are going to become mental health experts, but the mental health, three areas we talked about is mental health, a state of mental well-being, mental health difficulties or problems, which can be of part of normal adolescent development, and mental and behavioral disorders, more serious. You see, as we are going cascading down, becoming more serious. Of course, the gynecologist and obstetrician can definitely be of great help, and either in the first two at least, if not the third one. Another two slides. What are the difficulties you have? In the left-hand slide, if you see emotional, behavioral, cognitive, thinking, studying, and working identity. Now, just imagine that these are the issues the adolescent is facing, whether 11-year-old or whether 17-year-old, more in 17-year-old. They have emotional issues, the behavioral issues. I spoke with Supriya ji a few days ago, and we talked about the adults have something called as Meri Gadi, Meri Sari. You know, we are able to show off. You can show off your beautiful sari, or all these ladies are wearing. I was admiring them. And Meri Gadi. What have the adolescents to show? Only their bodies. Everything they have. So they start, and that leads to a number of complications and issues, and that's where we have to understand. And there's mental and behavior disorders, which will further compound the problem. So the idea is to let you know that many of the issues, many of the problems जो आपकी झोली में गिरते हैं, उनका origin mental health issues में होता है. And हम केवल उनको gynecological issues सोच के नहीं manage कर सकते हैं. We need a team, as Priya said, we need a lot of people there. The particular issues of mental health, which are given in this slide, coping with normal emotions, etc., that's to complete. This has already been talked about. One of the people spoke about the deaths. And you can see the top 5 causes. Suicide is also coming, self-harm, road traffic, drowning is coming here, but it's largely for this self-harm and suicide. And what are the main causes of many of the important causes of suicide are related to sex and sexuality, failed love affairs, early pregnancy, HIV, being abused, all of them are coming up. So immediately you see the connection that even is not only going to lead to abortions or STD or reproductive tract infections, it can also be leading to suicides. That's again, we start realizing, oh my God, we're dealing with issues which sometimes need multiple people. This is the status. There's some statistics I won't go on, just to let you know that pretty alarming statistics for suicide, for mental health disorders, loneliness and feeling anxious. This again, if I'm lonely, what do? I want to make friends. I want to buy your goodwill. So if you desire me, or if somebody propositions me for a kiss or further or fondling, and then going further to sex, I lead because I'm lonely. I don't want to be lonely. So the issues, when you ask a young lady why did she agree to have sex with somebody, you'll find very fascinating and interesting answer, which I found in the counseling which I've done for the last 3 decades or so. Substance abuse, of course, is one of the biggest one, and that has been alluded to. This is again just to let you know that in the 13-17 age group India, there's a book on the right side, which you see, I've taken the cover, which gives these things, and the burden of mental health problems, higher in urban, depressive disorders are commonest, and again, that depression leads to multiple issues related to sexuality, including bedroom problems. So one of the things when they grow up or they get married, they have bedroom issues, either less desire or hyper desire, both of them can come up. These are again some of the points taken from that book, talking about what are the percentages of depressed around 25%, which you can see on the left side. First, human figure shown sitting there, and distracted are 11% and many more so. These are the risk factors. Being bullied, the biggest one is coming up, and system use are highlighted. You can see in the there. And I just spoke on bullying on this evening because this usually missed out as a reason for harmful sexual practices or forced sexual practices or sexual abuse. Bullying can lead not only to touching or say few sentences to somebody, it could really lead to rapes and other ones, and that's also happening. So that's one of the issues. Violence and injuries, one of the areas not highly connected, but again with mental health. Here are some of the copies of my column which we talked about this year. I had a full page in Indian Express for 6 years every Sunday, and I used to get around 300 to 400 letters, Dr. Bharti ji, and I could answer only 5 or 6 of them in the whole page, because the first one which you see, keeping abreast of breast troubles, is 4 or 5 questions are answered there as a major one, because that's a commonest. So it comes up masturbation, body image, body hair, will I become pregnant? Will I not become pregnant? What do we do? So there are issues, and of course, there's a column which dealt with everything, all the counseling as an agony uncle, sexuality, mental health, friendship, etc. The crux of the point here is that from the column I addressed 18,000 queries on the UNFPA telephone helpline. We didn't have a lady doctor with us. So my wife doubled as the lady doctor. She's also an ophthalmologist, but she's been working within this area multiple times, and she did her MPH from Manila University. She also joined in hugely to answer, because somebody will say, I don't want to talk to a male, I want a lady. Please, I'll commit suicide. And my friends, around 280 of you listening to me today, what was that question of this girl? आई वोर माई ब्रदर्स का, मैंने अपने भाई का कच्छा पहना है, क्या अब मैं प्रेग्नेंट हो जाऊंगी, एंड क्राइंग लाइक एनीथिंग. So the issues are all minor, but what it means is they lack credible information. They are myths, misconceptions. And I said, as I have utilized classroom sessions and all that, the idea is to share, not to say, oh, what all I have done. Idea is we all can do it. Something or the other, as you said, that we should be doing that. And Priyaji spoke about it. Yes, we all should do that. The below one shows something myths which are there. And in every column, I would have around 30 questions. 10% of the questions were on masturbation by girls and by boys. Even if I write the answer, next time again, there are different questions on masturbation. It just doesn't end. These are the determinants of health, sexuality and health, deep connection. What is the early connection, substance use, and there it shows the round ones are showing a positive thing, and the triangles are the negative one. So if you have a positive relationship with parents, the early sex is postponed. Friends who are a negative role models actually lead you are a negative, and there is a problem with early sex and substance use and all of them. Having spiritual beliefs. This is WHO talking about, from 52 countries. It is there. It took 5 years to us to publish this document, and this is the main slide of the document. We're not talking about religion, we're talking about spiritual beliefs. This is the evidence, if anybody wants, that science and spirituality can meet together. It's come up. Parental engagement is and parental here also means quasi-parents like gynecologists, doctors, relatives. That's the definition of how we see a parent. Parent is not only biological parent. So we know that, as you've seen from the previous slide, they are a very protective factor. But what is the reality? Reality is given in the graph, which you all can see how little, only 21% of the children represent a good engagement. Otherwise, there's a low level of parental engagement ranging from 15% to a little 1/5 of students in India, around 20%, only have 80% do not have good parental engagement. So what kind of a society are we, ma'am? Our children are telling us, they're screaming and telling us, my parents or parent figures are not there for me. And then when the problems happen, when pregnancy happens, whom is to be blamed? I don't want to blame anybody, but the question, asking the question is the most important thing. What has India done in the area of MH? A lot of things have come through. Again, this slide is heavy deliberately so that you can refer to it. There's a National Mental Health Policy, Mental Health Care Act, prevention and promotion. But you see, again, what happens is that what happening is it's in isolation. There's no sexuality here. There are rights for reproductive and other sexuality. So everything is in silos. What you're doing is bringing all the things together to understand their deep connections. Of course, everything is connected. Even these are connected. This is a beautiful book, Helping Adolescent Thrive, which we call HAT. You can again refer to, it's available there. Effort made through the thing. So I'm coming on to the areas how we can assist the points coming up. This is more scientific and monitoring MH gap intervention guide, just for clean purposes. How to address, and again, I like to add to and thank Priyaji, Priya Vora, for making it easy. In fact, all of them from the first session to now, you made my job very easy, because every time somebody was talking about sexual abuse, etc. So it requires the implement actions by sectors other than health. That is where, and Priya also said, we need multiple teams, not only multiple teams of doctors, but various ones which we require. And I'll show you the next 1 or 2 slides will come up. The heads approach is the most important way of going about. It hasn't been brought out, but I know and understand all of you use that approach. It's simple. Actually, was for home, find out what the home condition is, who all are there, etc. Many times the abuse happens at home. Education and employment of that person, eating habits, exercise habits. A is for activities, other activities. You collect stamps, you do gardening, you want to sing, you dance, do Bharatnatyam, whatever. D is for drugs. Do you do any, do your friends do any drugs? Are you introduced to the drug? Do you know name of the some of the drugs? Sexuality, sexual practices, suicide, depression, and safety. So that's heads comes up. Now we can train healthcare providers to recognize health problems, deliver simple therapies, and that's where I said in that slide that the gynecologist obstetrician can at least do for 1 and 2, if not the 3. Refer the adolescent who think you are there and promote mental health by yourself laughing, being easy. I see many of the people here represented have done in a very nice, cool fashion. And Supriya ji is one example whose smile is all the time there because I saw her. And same with you, Bharti ji. I see you. You are the only 3-4 people I can see in the one slide here. So don't know whether others are smiling, but it's important. Let's not be stuffed shirts. Oh, I'm a big man. I'm from WHO. I'm here to assist that patient. That's why he has come to me. So that's what we do and teach adolescents the strategies, relaxation, stress reduction, overcoming, and problem solving. This is what I wrote and where you mentioned Bharati ji. This is around for 6 to 12 classes. There are 6 volumes, so thick each. We worked for so many years on this, and my book, this similar book, is also in Bhutan, who have acquired it as their school program. It's in their curriculum. This Yuva was extracurricular activity. Bhutan has I trained doctors there who themselves developed it, doctors and teachers, and it is one period a week for them is on life skills education and all these points coming up. I chose bullying here just to show you that it has all on sexuality, early pregnancy, nutrition, you name this, environment, how to give respect to the old people, everything. Many of the subjects are touched here. The 6 volumes, a beautiful one, including some of the Panchtantra tales to tell what is really life skills education. Conclusions and way forward. Again, a heavy slide. Recognize the public health and development of the adolescent mentality. It's not an individual is coming. You see, most of these individuals are affected by society and also in turn impact this society. So you're dealing with many of the points which you talked about today, LGBTQ and others, are social and economic issues and very nicely brought up. Those are areas. So immediately we have to link up. If I cure only one, I may not have done. And that's where I said that talking to adolescent, maybe by schools, and that example of doing Zoom, I think, who was done, I forget the name, very well done when I saw the slides of nearly 3,000
Dr.
children.
Sampath Kumari.
Dr. Sampath Kumari. And the excellent idea of the Zoom. I have done only largely because there was no Zoom. I used to go to schools and do that. Efficient implementation of strategies because we have them, combined strategy to program and strengthen parental engagement, need to live in place for reducing bullying and cyberbullying. Supriya ji had very kindly asked me to talk on cyberbullying 2 weeks ago, and more research is required. And this is to thank you all. I have benefited from being here with you all. Not only my gynecology, but my adolescent perspectives have been revised, refreshed, and whatever rust I had a little bit has been washed up. So I thank you. I've given my email here. Anybody who wants to ask for anything, most welcome. Thank you so much.
Thank you. Excellent, Dr. Nair. And we are indeed impressed by your dedication, commitment, and the impact you have made on adolescent health, especially the mental health issues. Because as you rightly said, the parental child relationship in the present society, I think, is dismally low. And very often, even when we go for the school education programs, which in our town we have done extremely well. We go every year to almost 40, 50 of the government schools and educate children. But when we call the parents for a meet along with the children, we do not get the participation from the parents due to various reasons, economic, social, and they do not come for the meetings to share, and the children's problems are never accepted by them. That is one thing we have been observing.
Yeah, please allow me another 35, 40 seconds to answer this. When I
Sure, sir.
started, I also used to go along the flow that they say, because the Japaigo people came home before WHO to ask me कि हमारे पास यूपी की ही लड़कियों को सेक्स एजुकेशन देने के लिए अच्छे गायनिकोलॉजिस्ट हैं, परंतु वहाँ के बदमाश लड़कों को ये देने के लिए हमारे पास कोई मेल डॉक्टर नहीं है, क्या आप ये कॉलम लिखते हैं दूसरी जगह क्या पाएंगे? मैंने कहा जी आ जाएंगे। तो एंड इट टर्न्ड आउट कि वो बदमाश लड़के नहीं थे, वो मिस इन्फॉर्म्ड थे। सेकेंड थिंग, व्हेन आई वाज गोइंग देयर, आई आल्सो यूज्ड टू गो एंड से ओनली विद द चिल्ड्रन. And then I realized that suddenly when the child goes home and talks about some of things, the parents get worried. Who told you this? किसने कहा? ये क्या? तुम ये बताने की चीज है? स्कूल में ऐसा लिखते हैं? क्या स्कूल है? They will come to the principal. So I made a point. I never took any money from any school, not 1 rupee ever. जरूरत नहीं थी, but they gave me a pot of plant or something which I exact होगा. So I told them कि अभी अब ऐसा नहीं होगा, because every year they would call me कि I want at least half a dozen teachers and half a dozen parents. Why do you want them? Everybody says हम केवल बच्चों का करेंगे. So I told them नहीं, इसलिए करेंगे because बच्चों का लेवल मेरे सेशन के बाद तो इतना ऊंचा चले जाता है, पेरेंट्स और टीचर का वो 1950 वाला या इवन 15th century वाला रह जाता है. So children suffer after my session rather than become better. So I changed it, and I know it is difficult, I entirely agree, and I'll stop here. I won't take more time, but I want to share with you. I personally faced this, but I started insisting on this. So they had to comply because उनको पता था ये आदमी अच्छा काम करेगा, ना पैसा लेगा, ना दमड़ी लेगा. So I did that.
Thank you. Thank you. Thank you very much, Dr. Nair, for those inputs. And I'm sure with all of us committed, the adolescents in our country will definitely have a brighter future. I thank Dr. Parag and the entire, and Dr. Supriya and the entire ICOG team for giving us opportunity to chair the session. I think Dr. Vidya Tobi is there. Dr. Supriya, if you permit her, for the final comments on this session.
Yes, yes. Unmute yourself, Dr. Poonam. Unmute yourself. I must thank Dr. Parag Biniwale sir for introducing Dr. PDN sir to
One
me.
talk is on. One talk is there in this
sorry,
session.
yes.
Dr. Suvarna.
So Dr. Vidya Tobi is there. I think she can introduce Dr. Suvarna.
Yeah. So very good afternoon, good evening. So it is very much my pleasure to introduce Professor Suvarna Khadilkar, a great and close friend of mine. And she is right now the Secretary General of FOXY, Professor Head of the Department of Bombay Hospital, Institute of Medical Sciences, Mumbai, and President MOGS 24-25, and she did very excellent work. And we all know that she's editor emeritus Jogi, and Jogi was brought to the greater heights in Suvarna's tenure, and National Secretary of Association of Medical Women of India 22-25. There are many accolades to her credit. She has many national positions, and she has achieved. And even the international position, I must mention that she's a Deputy Editor-in-Chief of International Journal of Gynecology and Obstetrics, FIGO Committee of Women at Menopausal Age 24 onwards, and even many. So over to Suvarna for her talk. Is Suvarna here?
Yes, she's there.
Yes.
Yes, I am here. And I want to thank as well as say sorry for the change in the schedule. And the topic is my favorite one. And I think Supriya knows it well, and she picked me up for the same. So, and because it is so favorite, in spite of all these meetings and this and that, I said, yes, I will take the topic. I will share my slides now. Yeah. So. Yeah. So let's start with a little bit of, I being an endocrinologist, please bear with me some more extra information that may be there on the slides on endocrine aspects of amenorrhea, puberty and other stuff. So what is puberty? It's a maturation process of the hypothalamo-pituitary gonadal axis resulting in the growth and development of the genital organs and concomitantly in physical and psychological changes towards adulthood leading to capacity to reproduce. So
It occurs between 8 to 14 years in girls and 9 to 14 years in boys. The changes associated with the puberty occur in an orderly sequence over a definite time frame. So the pre-pubertal period, period, as puberty approaches, three critical changes emerge in the low endocrine state of the childhood: adrenarche, decreasing repression of the gonadostat, and gradual amplification of the peptide and peptide steroid interactions leading to gonadarchy. So what is gonadostat? Early infancy to the 8 years pre-pubertal period, the LH and FSH are suppressed to very low levels due to highly sensitive negative feedback of low-level gonadal estrogen on the hypothalamo-pituitary sites, and an intrinsic central inhibitory influence is existent. Hence, both the mechanisms exist and they suppress the LH and FSH secretions. Now, early childhood, the negative feedback inhibition plays more important role, and in mid-childhood and pre-puberty, the central intrinsic inhibitor becomes functionally dominant. Late pre-puberty, the central nervous system, the pituitary gonadostat decreasing repression takes place, hence progressive responsiveness of the anterior pituitary to GnRH and follicle reactivity to FSH and LH takes place. So when gonadarchy ensures. Now, the hypothalamo-pituitary ovarian axis is in the state of repression till late pre-puberty, which progressively starts responding due to decreasing repression, and then the onset of puberty takes place. So what are the sequence of events of normal puberty? If you see here, if a girl is attaining her puberty, there is an initial increase in the growth velocity that requires both the growth hormone as well as thyroid hormone. The thelarche, that is the breast development, it requires the hormone estrogen. And so if there is no estrogen in the body, the thelarche will not take place. Puberty and adrenarche, that requires the androgens. And then there is a sudden growth spurt that we observe, and that is when the velocity of growth is the peak velocity that attains 9 centimeters per year, we say that the growth spurt has been there, and thereafter there is a deceleration of growth, and that is when the menarche comes in. So, menarche requires GnRH from hypothalamus, FSH and LH from pituitary, estrogen, progesterone from the ovaries. And after all this being there, if still a girl doesn't get her menses, it could be because her outflow tract is not patent, and therefore a normal patent outflow tract is very, very important for menarche to happen. So what is abnormal puberty? The classic definition of abnormal puberty is whether premature or delayed are based on the timing that is considered to be 2.5 standard deviation from the mean. So that is how we define, because usually in pediatric age group, adolescent age group, it is the percentile values which are more important than the absolute values. So various pubertal blues that we see, there is a delayed puberty, precocious puberty, isosexual puberty, and contrasexual puberty. So the various abnormalities you may see around the puberty. So the delayed puberty will have delayed growth, delayed menarche. Any of these either isolated or there can be a combination of these. So delayed menarche, that is the hypothalamo-pituitary ovarian axis is not functioning or taking time to get functional. Delayed adrenarche, that is lack of adrenal hormones, and delayed thelarche. So these are the various components of delayed puberty, and certain morphological changes that happen have been identified by Tanner and Marshall staging, which involves 5 points: the breast, pubic axillary growth, growth in height, and menstruation. So the sequence of development, as we already said, is like this. And if you can see the chart of the girls and the boys on the right side, the menarche, the breast bud, and then the pubic hair, which is scant in the beginning, that goes mature later. And the thelarche occurs between the breast growth occurs between 9 to 11 years, and estrogen is responsible for that. Therefore, intact HPO is important, and adrenarche happens, between the 10.5 to 11 years, and menarche is the onset of menstruation. This is the pictorial diagram of Tanner staging, and the various stages: stage 1, 2, 3. 1 is prepubescent, 2, 3 is pubescent, and 5 is postpubescent. So such 5 stages in females are described as given in this chart and in this pictorial diagram. I'm sure all of you are well aware of this, and the factors controlling the puberty, we are now multiple factors are there: the genetic factors, geographical factors, general health and nutrition, psychological factors, and exposure to light. Now if you see the western counterparts of these girls, they have the quite early puberty and early menarche compared to Indian, but now even Indians are catching up with their age of puberty. And this, I think we have already discussed. This is the normal puberty. Now, what are the hormones, as per Tanner stage? So if you see the Tanner stage 1, the FSH is in this range and estradiol is less than 10. And stage 2, stage 3, the various, this is good table for the postgraduates and for those who are appearing for the exams. It will be very useful for them. So how the hormones change from stage 1 to stage 4 of adulthood. So what about the delayed puberty? It is the hypogonadism, decreased sex hormones, and the sex characteristics are underdeveloped. And usually in girls, it is age 13 that we consider. So there is a lack of breast development by 13, more than 5 years between the breast growth and menstrual period, lack of pubic hair by age 14. So there can be functional disorders: hypogonadotrophic hypogonadism, hypogonadism can be the reasons for the delayed puberty and when women come with the primary amenorrhea. So the first group represents the temporary delays of puberty that are functional disorders, most commonly constitutional delay of growth and puberty. So there is low FSH, low LH, low testosterone or E2 as per boys or girls. Hypogonadotrophic hypogonadism, in this the pituitary failure results in deficiency of circulatory gonadotrophins, so low FSH, LH and low estradiol levels in girls. Now, hypergonadotrophic hypogonadism will have result from primary gonadal failure, resulting in elevated serum gonadotrophin levels. So, so you can have the normal, the primary failure and the secondary failure, and you can see how the changes take place in the pituitary, the ovaries, and the gonadotrophins, how the levels. So in normal, the levels of gonadotrophins are normal. Primary failure would have hypergonadotrophic. Secondary failure will have hypogonadotrophic status. Now, what is constitutional delay? I think I will skip a few slides. If you want, I don't have time, then I can skip. Otherwise, it is a very important slide. It will represent the extreme of the normal physiologic variations, single most common cause in both the genders and more often in boys than girls. And it is a diagnosis of exclusion, mind you. So children with constitutional delay are more likely to be short for age with a history of relatively normal growth rate. And there is always a delay in bone maturation. So delay in menarche. So women are worried that they have amenorrhea. They have never attained menarche, and family history of late menarche in the mother or sisters or delayed growth spurt in the father may be there. Sporadic cases are also seen, and puberty is not delayed beyond the chronological age of 16 years in females. The onset of puberty corresponds better with the bone age than the chronological age. Now, these are the various functional causes for primary amenorrhea, delayed puberty. But these are relatively rare. We don't see. But anorexia nervosa is a cause you may find it's coming up in even our country. Bulimia and psychological stress, extreme exercise, poorly controlled diabetes mellitus, and other things can be there. Then these are the causes for hypogonadal, hypogonadism, and there are isolated GnRH deficiency, Kalman syndrome, idiopathic hypogonadotrophic hypogonadism. So all these girls will have primary amenorrhea, pituitary transcription factor deficiency, panhypopituitarism, septotopic dysplasia, septo-optic dysplasia, syndromes like Prader-Willi, Noonan syndrome. All these may lead to hypogonadotrophic hypogonadism, and these are the congenital or hereditary causes, and these are the acquired causes. So quite an exhaustive list of various causes of hypogonadotrophic hypogonadism and amenorrhea. So these are the various acquired causes like CNS tumors, craniopharyngiomas, and other trauma, surgery, etc. These are hypergonadotrophic, where we have the girls with Turner syndrome, 45X, or there can be a 46XX stroke 45X mosaicism, maybe there. Swyer syndrome, mixed gonadal dysgenesis, where there are XX and XY together, pure ovarian agenesis 46XX, galactosemia, FSH or LH receptor gene mutation can be there in the girls, and other acquired causes like radiation, chemotherapy, trauma, surgery, infection can be there in the hypergonadotrophic. Now, how do you evaluate the pubertal delay and a case of primary amenorrhea? When there is totally absent or had started and then it got arrested, we must know. Then family history of constant delay in puberty, family history of infertility, perinatal history, prior medical illness, medication, and psychosocial. So the history of nutritional habits, how eating pattern, whether any psychological problem is there, neurological symptoms can be there as headaches, visual disturbances, sense of smell should be noted, hypoglycemia, cancer history, any history of chemotherapy should be noted, history of which is compatible with in boys, there can be this kind of history may be there. Physical examination, you must note down the height, weight, BMI, weight for the height, and the growth velocity, arm span may be noted, and pubertal staging should be done. And there can be systemic examination where some physical features may be noted. There can be scoliosis, there can be short stature, there can be broad chest, webbed neck. All these go on well with Turner syndrome. And visual field examination like fundoscopy must be done, and the sense of smell should also be noted. So what is important is the physical examination, and that is the mid-parental height. In that, what is important is the mid-parental height. The girl's father's height in centimeter plus mother's height in centimeter divided by 2 minus 6.5 centimeter will give you the average mid-parental height, and that should be our aim. And if she is much shorter than this, that means she is a less short stature, and there are short stature girls who have amenorrhea have some genetic disorders. So then we have the physical other, you must note the breast development and whether what stage of the breast development, which Tanner stage is there. Axillary pubic hair may be noted, vaginal mucosa changes, and how any there is a, the clitoromegaly is there. So all this. So these are the various practical pointers in clinical examination, just to summarize. So anemia, nutritional deficiency, weight, height, other abnormal features, any thyroid swelling, skin. So all this must be noted down, and each one will have a specific pointer to, yes, you may be looking at this particular abnormality. So initial screening should include complete blood cell count, electrolytes, renal, liver, panel, ESR, LH, FSH, DHEAS, testosterone levels, estradiol, thyroid function test, serum prolactin, and cortisol, ACTH, and bone age. And wherever there is a need, you may give challenge tests for knowing what exactly hormonal abnormality the girl has. So karyotyping may be required, but believe me, in a clinical practice of gynae endocrinology, once you see a patient, almost your diagnosis is complete in the clinical examination only, and prior history, of course. And you do the karyotyping just to confirm what you suspect is there. And also, if a girl is short, you must do a physical karyotyping, and you suspect in presence of genetic syndrome, you should do it. And GnRH stimulation testing, only limited benefit may be required. So these are the various levels that you do. And the imaging, the bone age may be obtained at the initial visit to assess skeletal maturation, and repeated over time if needed. Skeletal age more closely correlates with the sexual development and the chronological age. So bone age more than 13 for girls less likely to be constitutional. Now, you should do the pelvic ultrasound to see if there is any absence or presence of uterus, absence of presence of ovaries, MRI brain when you suspect any hypothalamic hematomas or any other intracranial lesion. And you must do it especially with hypogonadotrophic hypogonadism. Then this is the flow chart for history physical examination, how you should go ahead with the workup of a patient who has delayed or interrupted pubertal development and primary amenorrhea, and in phenotypically females. So you must first see how the breast development is there. If the secondary, I'll just skip this because this all is given in few slides, which I will show you now. So there is the final diagnosis after seeing high FSH. You must do the karyotype, and then if it is normal, then 46X6. If it is abnormal, then 45X or 46XY. If there is a immature secondary sexual characteristics, and if there is a low or normal FSH, the normal pituitary function testing, then constitutional delay, isolated gonadotrophin deficiency, hypopituitarism can be there. And the mature secondary sexual characteristics, and she is having no menarche. Any distal genital tract obstruction must be first ruled out. Mullerian agenesis, maybe that is MRK syndrome, may be there. And T4, TSH should be done. And maybe you are looking at hypothyroidism if FSH and is prolactin is elevated, then hypothyroidism can be suspected. So now I will go to certain case reports, which I'm sure all of you will know. Yeah, so can anyone tell me, first question when a primary amenorrhea comes, is there a normal development of secondary sexual characteristics? Your answer, if it is no, there is no secondary sexual characteristics, then what do you think? There is no estrogen, think hypogonadism or hypogonadotropism. So these are the girls who have there are no sexual characteristics at all, no breast development, no the pubic hair or axillary hair. Now, if the next step would be, then you should see the FSH level. The other important test is
with FSH level, if it is low or normal, that means FSH is not being secreted in adequate amounts. So you suspect hypogonadotrophic hypogonadism. If FSH is high, that means that the gonads are not getting activated at puberty, and the FSH is therefore getting high, or there is a completely dysgenetic gonad which is causing the high FSH secretion. So
Suvarna,
all
sorry,
these
but
deficiencies.
you need to wind up, please.
Yes, yes. So this is, I will just go through the cases which are very, very important. I will see the pictures. If any of the, is there any interactive platform, then others can put in the chat what they are looking at. So gonadal dysgenesis can be chromosomally abnormal, chromosomally normal. So classic Turner syndrome is 45XO, Turner variants, and these can be there. And chromosomally normal would be 46XX pure gonadal dysgenesis or 46XY Swyer syndrome. So if you look at this picture, there is a spot diagnosis, absence of uterus, both ovaries normal. That means Mullerian agenesis. Her chromosomal analysis has to be 46 XX. Okay, so this is the 46XX uterovaginal in an uterovaginal agenesis. Then if there is a normal development of secondary sexual characteristics, think of pregnancy, Mullerian anomaly, androgen insensitivity, and even the genital tuberculosis, which is very common. So these are a few pictures of genital tuberculosis where there is a Asherman syndrome. So these are the pictures. Spot diagnosis here, anorexia nervosa, that is possible. Then imperforate hymen, the obstruction to the outflow tract. So simple, you can see the blue tinge, and there is a cruciate incision taken, and the blood which is accumulated is flowing out. Then hypergonadotrophic, I can just go through some pictures there. Can you see Turner syndrome, webbed in neck, and the cubitus, the angle is at the elbow is there. We can pick up just clinically. There is no need for doing chromosomal analysis here. So gonadal dysgenesis, autoimmune oophorytis, chemotherapy, all these causes can be there for primary ovarian failure. This is another, balanced translocation in one of my patients. The karyotype is seen here, 46XT, and there is a translocation between X20, Q22, Q12. So that is how the when it goes. Then, yeah, again a spot diagnosis. You can see the short metacarpal Turner syndrome. Then another is here, there is no hair anywhere, but the breast has developed female sexual characteristics, amenorrhea, normal looking female. The spot diagnosis is androgen insensitivity syndrome. Now another case is Swyer syndrome, where she failure to attain puberty. She developed a mass, open and closed laparotomy. She came to us. Again, there was a 46 XY, so it was a pure gonadal dysgenesis, male type, and then there was no uterus, it was just a nodular uterus. But this is a Swyer syndrome where one side tube is developed. This is the tumor, and there is a small query nodular uterus that forms, and the XY karyotype. Okay, so that's a complete Swyer syndrome. So to conclude, the history and physical examination is the most important step in assessment of primary amenorrhea and making clinical diagnosis. Pelvic ultrasound, karyotyping, and serum FSH will be needed to document the abnormality. Diagnostic laparoscopy may be required to take a biopsy in inconclusive or non-invasive testing, and health concerns and fertility are important issues for which early diagnosis is
essential. So amenorrhea may be complex, but with proper evaluation and care, and above all, clinical experience is most important. It is far from impossible to diagnose and treat. Both primary and secondary amenorrhea invite a lot of psychological, social dilemmas, but proper counseling and timely management will overcome. Thank you so much.
Thank you, Dr. Suvarna. It was an excellent talk. And as we all know that reproductive endocrinology is to your heart, you have explained so nicely each and every aspect of puberty in primary amenorrhea. It was crystal clear for everyone. I think there will not be any doubts or anything. But if anybody wants to ask question, please put in chat box. Suvarna will answer in the chat box only because she has exceeded the time limit because it is very dear to her heart. We all know. The
You
cases
should
were
give me
also-
one day, 12 hours.
Thank you all the chairpersons and speakers of session 2. Now we are quickly moving toward the session 3. And there is slight change. Dr. Hema Divakar has to join some urgent meeting at 6:45. So we will quickly move toward the third session. And chairperson for third session is Dr. R. Premlatha. She is the consultant HOD of head of the Department of Obstetrics and Gynae at Dr. Mehta's Hospital, Chennai. She is the retired director. Now, second chairperson is Dr. Kiran Pandey. She is the professor and former HOD, Department of Obs and Gynae, GSBM Medical College, Kanpur. Next, third chairperson is Dr. Rita Kumari Jha, who is the vice president, National ISOPAB, and president, ISOPAB Patna chapter. And now I request our chairperson to invite our first speaker, Dr. Hema Divakar, and I would like to thank Dr. Chandan for accepting this.
Yeah, over.
Thank you, Doctor. At the outset, I thank the ICOG Governing Council, all the chairpersons and the Adolescent Committee, FOXY, for giving me this opportunity to be associated with this adolescent certificate course. I'm very happy and privileged to invite Dr. Hema Divakar for this wonderful thing, talk on PCO in adolescence. And she is the past president of FOXY, and she's the medical director, Divahar Hospital, and CEO, chairman of Asian Research and Training Institute for Skill Transfer. She's the chair of Well Women Healthcare at FIGO, Dean, KCOG, Karnataka College of Obstetrics and Gynecology. She's the president, Karnataka Association of Healthcare Providers of India, ex-vice chair for FIGO PNCD committee, and advocate of delivering quality healthcare convener, Manyata program. And she needs no introduction. She has so many awards: FIGO Women's Achievers Award, Global Asian Award in 2018, FICCA Award for Excellence in Capacity Building. Over to Dr. Hema Divakar.
Namaskar. Thank you very much. And with my respects to all the three chairpersons, Premlata, Kiran, and Rituja, and my sincere thanks to Chandanji for just agreeing for the reshuffle, and so also Supriya and Poonam. My congratulations to the ICOG office bearers, Parag, Saritha, and the team. This is the most well sought after program, the certification courses which have become very famous in the recent past, and I really think that it's a great learning experience. Adolescence. Listening to all the previous speakers, we know that a young child is growing up into an adolescent, but seems to be growing with so many problems, because there are quite a lot of heavy deliberations which make us feel that this phase also needs a lot of attention, because you reap as you sow. And this is what makes the adolescent the very crucial phase for diagnosis, underdiagnosis, overdiagnosis, misdiagnosis, appropriate diagnosis, and the way forward. It sets the path for her life. The PCOS especially falls into this category. Overdiagnosis of PCOS, it has become the style statement, PCOS, unnecessary psychological distress, having diagnosed with the future subfertility, which all moms are worried about the adolescent. Then, if assumed physiological, it may sometimes be underdiagnosis, likely transition into adulthood, and long-term consequences, which the FIGO is constantly hammering on my head about PCOS today and NCD tomorrow. So this is as complex as It could be PCOS starts in the adolescence or teenage, but unfortunately, not always diagnosed because clinical expressions are varied and it's overdiagnosed at that age. What could be the simplistic way of avoiding the spectrum of under overdiagnosis? What are the investigations that one would do, and how would you take the management of this case further? Poonam, just confirm whether you can see the slides and hear me clearly, please.
Yeah.
Yeah, great. So this one slide is mind-boggling. It makes you feel how complex the clinical syndrome of PCOS can be. There's a genetic element, there's an environmental multi-gene interaction, there is the lifestyle issues, the hormone changes and obesity exacerbating. It's as if you're holding a magnifying glass and looking at all the problems. It's like a mega affair. Increased androgens on one hand, giving rise to hirsutism, acne, increased insulin resistance, then long-term problems type 2, diabetes and metabolic syndromes, the ovarian follicles into trouble because of both these factors, the increase in the incidence of anovulation, increased estrogen, which leads to menstrual disturbances, which is quite commonly the problem with which the adolescent and her mom seeks care. Of course, underlying all of these, as Dr. Nair said, psychological issues, the body image, self-esteem, depression, anxiety, the mental well-being also has to be properly noted and very sensitively, non-judgmentally tackled. So incidence of PCOS at 6 years, 6%, 10 years, 18%, 15 years, 26%. Easier to detect in older girls when the ovarian size increases. 30% detection is by trans-abdominal scanning, and if you want to go only by the scan diagnosis, nearly 100% of the times you can count the follicles by transvaginal. Why should we bother to diagnose PCOS in the adolescents in the first place? That's because early detection and early initiation of care. So the level A evidence is timely diagnosis of PCOS in symptomatic adolescent girls is really, really important to initiate appropriate screening and treatment thereafter. Level C are the other two levels of evidences, validated diagnostic criteria supported by robust clinical and hormonal findings, which are really needed to avoid overdiagnosis and unnecessary treatment in otherwise normal healthy girls without hyperandrogenism. This point really has to be noted because number of times metformin and other drugs unnecessarily started for the young girls with the overdiagnosis. Research is evaluating the long-term interventions of what the PCOS in adolescent can cause in her later life. So living in the present is the mantra. So let's just focus on what really needs for the appropriate diagnosis of PCOS, not under, not over, appropriate diagnosis of PCOS. It has come a long way from the NIH criteria in 1990 to 2003 ASRM criteria, and then the latest ones being from our own PCOS society as well. And all of these talk something about the menstruation, either oligo or chronic anovulation, something about hyperandrogenism. There is polycystic ovarian morphology on the ultrasound, and certain of the biochemical tests will take you further to rule out or confirm. Exclude all other causes of all of these which are appearing on this slide. Other etiologies of excess androgens and menstrual irregularities have to certainly be excluded, and you've seen the next one with heavy menstrual bleeding by Chandanji will bring to notice about what menstrual irregularities can happen. Can we use the same criteria to diagnose PCOS in adolescents? One would say no, because normally in adolescence, before the ovarian pituitary axis matures, there is likely to be oligomenorrhea. There is likely to be amenorrhea. Some degree of acne and multicystic ovaries is a common picture. Moreover, at puberty, the growth is associated with profound metabolic changes. So the basal metabolic rate slows at the end of the linear growth and predisposes to weight gain. So it's a mixed picture, and you must not ever rush to label a normal adolescent as a case of PCOS. Why the adult criteria is not applicable to adolescent is something which we should know. because 85% of anovulatory cycles happen in the first year after menarche, 59% persist even until 3 years, 25% are still anovulatory at the 6th year after the menarche. These points should absolutely be noted, and please do not rush to overdiagnose. Metabolic features, the insulin resistance, increased insulin due to high growth hormone. Then the hyperpulsatile GnRH secretion, decreased levels of SHBG, increased ovarian and adrenal androgen is a rule in the normal adolescent. So it cannot be misquoted, misdiagnosed. However, all of these will return to normal at the end of normal puberty, but those who are destined to move ahead with PCOS will remain with all these elevated levels even beyond the 4 to 6 years after menarche. The ultrasound diagnosis, 40% will show a change in pattern at 2 years, 33% at 4 years after menarche, and physiological during early adolescence is the PCOM, which is diagnosed at the ultrasound. Not associated with abnormalities in ovulation, menstrual cycle duration, or increased androgen or increased insulin resistance. So there is an overlapping picture. So please do not rush to overcall. In fact, when you send her for a routine scanning because of pain in abdomen, or because scan is the sixth sense beyond our five senses, and invariably the bottom line reads PCOS correlate clinically, and that triggers off hyperanxiety. So the clinical manifestations can be gross, as how it's shown in this picture. Besides oligomenorrhea and amenorrhea, ovulatory dysfunction, hirsutism, acne, and alopecia, which is rare in adolescents. So android or gynecoid type of pelvis, and the upper limit is 80 centimeters. Metabolic aspects, obviously the BMIs will be high, obesity, insulin resistance, impaired glucose tolerance, and oftentimes we have debated how soon and how often should you check for all of these. These pictures speak for themselves, and it is not difficult to diagnose even with the phenotypic hyperandrogenic manifestations with menstrual disturbances that this could be a case heading towards PCOS. Menstrual irregularities are not a proof of adult chronic anovulation. Kindly remember that. Persistent oligomenorrhea for 2 years post-menarche with elevated LH or androgens is diagnostic of PCOS. So you got to be patient and wait and not jump into conclusion within a year or two after menarche. What are the kind of investigations that one may want to do? AFC and the volume, AMH, androgen profile, assessment of glucose intolerance, insulin resistance, lipid profile, or the test for differential diagnosis such as prolactin, thyroid estimation, 17-OH progesterone, ACTH stimulation. Oftentimes you will find PCOS profile. That is the only kind of investigation one-liner that we write, and various labs have various array of tests being done, often again leading to misinterpretation. No single test is diagnostic, and PCOS should be diagnosis of exclusion. What is the category, what is the recommendation, and what is the grade of evidence? So let me call out only those which have a high grade of evidence. Ultrasound should not be used for diagnosis of PCOS with a gynecological age of less than 8 years after menarche due to high incidence of multifollicular ovaries in this stage of life, because the high resolution machines, many follicles picked up, and you just count them and you label her as PCOS. Not fair for an young girl who's less than 8 years of menarche. Another is transvaginal approach is preferred if the adolescent girl is sexually active, and if acceptable to the individual, that should be used for assessment, as we have already outlined. The transabdominal will miss many of these findings. Screening for insulin resistance, hyperinsulinemia in adolescent PCOS. Which test to do and which not to do. Clinically, acanthosis nigricans and truncal obesity. The gross pictures, which you will see here. Biochemically, the fasting lipids every 1 to 3 years, 75 gram single step test with or without the HbA1c estimation. Insulin levels not done due to assay variability, because depending on the age and gender, there's a lot of inaccuracy and absence of validated assays in our own country. So unnecessary investigations are going to be avoided. Screening for glucose tolerance, very, very important. As the adolescent moves towards early adulthood, we should define her glycemic status because it has a huge incidence in Asian countries and also marked with obesity, insulin resistance, and the glucose impaired status will set the stage for hyperglycemia in pregnancy and all the multiple complications thereof. HbA1c measures the efficacy of glucose lowering treatment, and normal HbA1c cannot exclude the diabetes mellitus or IGT because anemia and HbA1c, the reports clash with each other. So diagnostic algorithm, what should it be? Step 1 is irregular cycles, clinical hyperandrogenism, zoom, you get to the diagnosis right away. Step 2, if no clinical hyperandrogenism, that means no acne, no hyperpigmentation, no hirsutism, then you need to do biochemical tests for hyperandrogenism because they are not phenotypically evident. Step 3, only if irregular cycles or hyperandrogenism, ultrasound for the PCOS, and if positive, then the diagnosis can be confirmed. So in a nutshell, in summary, the diagnosis, evaluation, and treatment, that's the last thing I'll come to before conclusion. Please, let me emphasize again, exercise great caution in diagnosis. Before diagnosis with clinical features of androgen excess, if oligomenorrhea has not persisted for more than 2 years, don't jump and overdiagnose. These girls can be at a risk of PCOS. Avoid misdiagnosing physiological pubertal changes as PCOS. Postpone the diagnosis. Frequent longitudinal re-evaluation is the rule. Very strict criteria laid way back in 2006, oligomenorrhea or amenorrhea, clinical hyperandrogenism, biochemical hyperandrogenism, hyperinsulinemia, and polycystic morphology. These 5 points, simple to remember, good to go. Treatment, depending on the requirement. Many a times, obesity tsunami is there and we need to get that into our fold. Impaired glucose tolerance, of course, needs the treatment. And even if there is the absence of a definitive diagnosis, some of the symptoms may need to be alleviated, and hirsutism and cosmetic treatment is now the first line. So weight loss with calorie restriction, which is beneficial both for reproductive and metabolic dysfunction. And in the last 1 minute, I'll just outline 2 or 3 more options of the treatment. Hormonal contraceptives, which is often the first line of management for menstrual abnormalities. Cyprotenone acetate and some combination of hormones can also take care of hirsutism and acne. So to conclude, overlap between normal pubertal development and characteristic features of PCOS may confound an accurate diagnosis of PCOS. So delay the definitive diagnosis. This is a level A evidence. Other disorders associated with irregular menstrues or hyperandrogenism need to be excluded by not just blindly labeling her as PCOS. That is also the level A evidence. The level B is even in the absence of a definitive diagnosis and the lack of an approved therapy for PCOS in adolescent, treatment options that alleviate the current symptoms or decrease the risk of subsequent associated comorbidities are indeed recommended. And great caution need to be exercised before diagnosing PCOS in adolescent girls with clinical features such as androgen excess, hirsutism, biochemical androgenism, if oligomenorrhea does not persist over 2 years. Although obesity, insulin resistance, etc. are other common findings in girls with hyperandrogenism, these features should not be used to diagnose PCOS. So in a nutshell, there is a lot happening in PCOS, but there is a lot of restraint that a clinician has to exercise for the benefit of the girl herself and decreasing the anxiety for her mother and the rest of her family. So with this, I've just placed some dots to be connected in our own minds in the short span of 15 minutes allotted. So next time you see an adolescent with PCOS, get your Antenna rolling into how many years, what is manifesting, what exactly you need to do, and not overcall or undercall this diagnosis. Namaskar, and thank you very, very much. Again, thanks to my next speaker, Chandanji. Thank you, because I really need to go for another meeting, which is very crucial for our FIGO team. So I have just excused myself a little bit from there, and I'm thankful for the change in order. Thank you.
Thank you, Dr. Hema. You have rightly taken us through all the importance of overdiagnosis of PCOS and the right way to diagnose. Really, it was a very enlightening speech. Thank you very much.
Thank you. Thank you so much.
Thank you, madam.
Excellent
Thank you.
presentation, Dr. Himaji. Excellent presentation about PCOS.
Thank you.
We should not overdiagnose it. It is very crucial to think about it, but we should be doubly sure that it is PCOS. Then only we should proceed for diagnosis. And ultrasound is not the sole diagnostic tool to diagnose PCOS. We should early doubt about it by features of hypoandrogenism and amenorrhea or menstrual irregularity. Then only we should proceed. And treatment always be a holistic approach. Lifestyle is the first one, and then pharmacotherapy and mental support is very essential and very crucial. Thank you very much for your brilliant.
Thank you for summing it up so beautifully, Ritaji. Thank you. Thank you, Supriya and
Thank you very
Poonam.
much.
Thank you. Lots of love and claps for you, madam, from the audience.
Yes,
coming
yes, yes.
throughout.
Lots
Thank
of
you.
them. Very clear, very clear.
Poonam,
Now, next speaker.
the chairperson is there now?
Chairpersons?
Rita,
Dr.
you
Rita
just
is there.
you introduce Dr.
Yes,
Chandan.
yes. It is my privilege to introduce Dr. Chandan Kachru. She is a senior consultant OBGY in adolescent health, Cloud9 Hospital Sector 47, Gurgaon. She is a master trainer in adolescent health from Imperial College. She has done master course from Imperial College London, European training in adolescent health from UTech, and she is executive member of Adolescent Health Committee, chairperson Adolescent Health Project, Udan of Haryana OBGY Society, and so on. She is a national master trainer of many programs. And over to Dr. Chandan Kachru.
And a big thank you to madam for
Much
just
all the team who has organized this excellent training program. Thank you, Dr. Supriya ji, and thanks, Dr. Parag, for inviting me. So I will start my presentation.
Yes.
So we'll talk about the heavy menstrual bleeding in adolescents. There are always new and harder challenges to take on, and a true winner will embrace each one. So another challenge in adolescent health is to treat the heavy menstrual bleeding, which is a very common symptom in adolescent girls and is self-reported. 7% of 16-year-old schoolgirls and about 13% of them receive treatment for heavy periods. Heavy menstrual bleeding reduces quality of life, impairs social support and school participation, and triggers serious health problems such as iron deficiency anemia. And still many girls and women affected by it do not consult the doctor. By definition, it is defined as excessive menstrual blood loss that interferes with a woman's physical, social, emotional, or material quality of life. It can occur alone or in combination with other problems. Some papers define it as a blood loss of more than 80 ml per cycle. Menstruation in adolescents can be irregular because of anovulation and immaturity of the hypothalamic pituitary ovary axis. Cycles typically occur every 21 to 45 days and last 7 days or fewer, like explained by Dr. Hema just now. Now, how to assess the heavy menstrual bleeding? This is one tool which we can use, very much available on the net. So we have to see the frequency, the duration, the regularity, flow volume, whether it is heavy, normal, or light, intermenstrual bleeding, if any is there, and if anybody is on hormones, how to assess it. Now, disorders in regularity can be there. The menses can be irregular, variation more than 20 days over a period of 1 year, absent menstrual bleeding,
no bleeding in 90-day period, disorders in frequency like 1 or 2 episodes in a 90-day period, more than 4 episodes in a 90-day period. And similarly, we can define other irregular bleeding periods. But prolonged menstrual bleeding is menstrual periods that exceeds 8 days on a regular basis. Now, how do we classify this heavy menstrual bleeding? And it is classified according to the standard Palm-Cohen system. And we can use this diagram, and we know that there are structural causes and there are some other causes like coagulopathy, ovarian dysfunction. This is non-structural, which are more commonly seen in the adolescent population. Now, mostly the causes can be anovulation, bleeding disorders, pregnancy, thyroid disorders, infections, foreign bodies, and endometriosis, which is the least talked about. Now, differential diagnosis of HMB in adolescence is endocrine causes. It can be anovulatory bleeding, PCOS, thyroid diseases, and others. Bleeding disorders like von Willebrand disease, platelet dysfunction, thrombocytopenia, which is commonly seen in India among the state, and pregnancy like abortion, ectopic pregnancies, gestational trophoblastic disease, infections like cervicitis, disorders of uterus, medications like progesterones, then trauma, foreign body, or hemorrhagic ovarian cysts, likely endometriosis. Now, on examination, physical examination of the patient who presents with acute heavy menstrual bleeding should include assessment of the hemodynamic stability, including orthostatic blood pressure and pulse measurements. Dermatological signs of anemia and bleeding disorders include pallor and presence of bruises or petechiae. An abdominal examination should be done to assess for distension, any hepatosplenomegaly, or any abdominal masses. In adolescent girls with heavy menstrual bleeding, speculum examination typically is not required. If a patient has vaginal bleeding, make sure this is appropriate with the sexual maturity level, that is, sexual maturity rating, Tanner staging 3 and above, and not due to other sources like trauma. Then what are the lab tests we do? That is beta HCG. This is the first one to exclude the pregnancy. Then complete blood count, blood group and cross-match sample, which is very important. Serum ferritin levels, coagulation profile, VDRL and other sexually transmitted disease. HVS if sexually active. PCOD profile if you know that she's a known case. Ultrasound lower abdomen if sexually active in case bleeding doesn't stop to rule out other causes, especially in patients who are only sexually active. And this is not mandatory. Others are fibrinogen, von Willebrand factor activity and antigen, and PTA and factor 8 activity. Ultrasound, like Dr. Hema said in PCOD, similarly here also routine ultrasonography should not be obtained solely for workup of heavy and menstrual bleeding in adolescents. However, it can be considered for patients who do not respond to initial management. Now, what are the common bleeding disorders in adolescents? The most common bleeding disorder in adolescents who present with heavy bleeding is von Willebrand disease, platelet function defects, thrombocytopenias, and clotting factor deficiencies. And thrombocytopenia can be congenital or acquired. This is the flow chart which shows us the various common bleeding disorders in adolescents. Now, presenting symptoms in approximately 1/2 of adolescent girls with bleeding disorders present with heavy menstrual bleeding at menarche. Others may not present until cycles become ovulatory. Of adolescent girls and women with an inherited bleeding disorder, 75 to 80% report having heavy menses as the most commonly cited clinical manifestation of their disorder. Now, although classically irregular heavy menses are associated with bleeding disorders, adolescent girls may have prolonged menses or irregular menses due to anovulation superimposed on bleeding disorder. That is why we can even miss this bleeding disorder in the adolescents. So we have to keep that in mind. Recurrent hemorrhagic corpus luteum with or without rupture or hemoperitoneum with ovulation also can be gynecological indications of bleeding disorder. And anemia that results from bleeding can cause associated symptoms of headache and fatigue, and we should be taking care of these headaches and fatigues as symptoms. Now, what is the management? The acute management includes the choice of treatment of acute management dependent on clinical stability, overall acuity, and suspected etiology of the bleeding and underlying medical problems. Hemodynamically unstable or actively bleeding heavily should be hospitalized for management. Volume expansion with crystalloids, hormonal therapy, and iron replacement therapy should be initiated. And if the patient is very sick, you can even consider blood transfusions. Now, myth about giving hormones, especially in adolescents, many are very reluctant. Most girls have completed 95% of their growth by menarche, so concern about the use of estrogen and closure of epiphyseal flates should not preclude hormone use for the treatment of heavy menstrual bleeding, according to ACOG. Now, management also includes in the absence of contraindications to estrogen, hormonal therapy for acute heavy menstrual bleeding can consist of IV estrogen every 4 to 6 hours, or alternatively, monophasic combined oral contraceptive pills in 30 to 50 microgram ethinyl estradiol formulation can be used every 6 to 8 hours until cessation of bleeding. Once bleeding has stopped, typically within 24 to 48 hours, a combined OCP tapering regimen should be initiated. If bleeding has not stopped or significantly improved within 24 to 48 hours, a hematologist should be contacted. Tapering regimes may vary, and doses of combined OCP should be maintained at the level needed to prevent bleeding until the hemoglobin has increased to a level adequate for the patient to tolerate a potentially heavy withdrawal bleed. So just wait till she settles down. In girls and adolescents with underlying bleeding disorders, continuous use of combined OCs may be optimal. Progesterone-only therapy is effective for cessation of bleeding of our girls and adolescents in whom estrogens are contraindicated or not tolerated. Oral medroxyprogesterone 10 to 20 milligram every 6 to 12 hours or norethindrone acetate 5 to 10 milligram every 6 hours can be used. Depot medroxyprogesterone acetate is not the first-line therapy because of the difficulty to titrate it. But I have recently come to know that certain places only this is available. So the management also depends upon where you are working. Suppose you don't have anything, you have only this. So for the time being, you can use it for the control. Now, this is the FDA improved chart, which says how to give the estrogens. This chart, or flow chart also is available on the net and can tell you systematically what is the therapy like, which I have already briefed. Non-hormonal therapy, use of antifibrinolytics such as tranexamic acid or aminocaproic acid in the oral and IV form may be used to stop bleeding. Although there is a theoretical risk of thrombosis, the concomitant administration of Tranexa and OCPs has been used when monotherapy has failed. This is actually the first line of treatment before you start the OCPs. The role of transfusion, hemodynamically unstable patients or those with severe symptoms of anemia should be offered blood transfusions, and they respond to hormonal management and iron therapy quickly and tolerate anemia better than do the adult patients. Theoretically, avoiding exposure to red blood cell antigens may reduce the risk of hemolytic disease of the newborn in any future pregnancy. So we usually don't give the blood transfusion unless it is really, really needed. The American College of Critical Care Medicine and the Society of Critical Care Medicine advocate for restrictive red blood cell transfusion practices and transfusion only for a hemoglobin of 7 grams per deciliter or less to limit complications of allogenic transfusions. Decision to transfuse should be based on hemodynamic status and presence of active bleeding. Now, role of surgery. Surgery should be considered when there is a lack of response to medical therapy, if the patient is clinically unstable despite initial measures, or when severe heavy bleeding warrants further investigations, such as examination under anesthesia. Now, endometrial ablation, uterine artery embolization, and embolization and cystectomy are invasive measures that can cause infertility and should not be considered in the adolescent population unless absolutely necessary, such as in life-threatening situations. Surgical options that spare fertility include intrauterine balloon tamponade and suction evacuation or suction curettage. Concomitant hysteroscopy may be of value for those patients in whom intrauterine pathology is suspected or if a tissue sampling is desired. Additionally, concomitant placement of levonorgestrel-releasing intrauterine device for long-term management should be considered in this setting. Recent advances has been very, very appreciative of the LNG IUD in adolescents. Adolescents in whom bleeding disorder has been diagnosed should be reminded that products that prevent platelet adhesions, such as aspirin or non-steroidal anti-inflammatory drugs, should be used only with the recommendation of a hematologist. After correction of acute heavy menstrual bleeding, maintenance hormonal therapy can include combined hormone contraceptives, oral, and here comes the role of LNG IUDs. And non-hormonal treatment for anemia may include oral iron supplementation and dietary optimization. The WHO defines a hemoglobin threshold for 12 grams for adolescents. So iron deficiency generally is identified as serum ferritin concentration of 15 micrograms. Adolescents with heavy menstrual bleeding are at even higher risk of iron deficiency with 0.4 to 0.5 milligram of iron lost with every 1 ml of blood. So first line therapy for iron deficiency anemia includes oral iron supplementation along with dietary counseling to increase oral iron intake. The CDC recommends that adolescent girls and women have anemia receive an oral dose of 60 to 120 milligram per day for iron. There is emerging data that once a day to every other day dose scheduling is more efficient than multiple doses because increased level of released hepcidin can decrease the iron exhaustion. Duration of therapy should be directed by the severity of anemia, and we can correct it during the 3 to 6 months course, and a ferritin level is very good to tell us whether it has been corrected. So this is something very new, which tells us about heavy menstrual bleeding clinics for adolescents. Like we have the adolescent clinic, some of the regions as pilot projects have started what we call as spots, dots, and clots clinic. They have a referral triage. These are small clinics which are connected with a referral hospital where in case of needed further management, the patient can be directly referred to the center for a interdisciplinary coordinated approach with a gynecologist, adolescent pediatrician, hematologist, endocrinologist, and a psychologist, where all the components to implement an interdisciplinary hematology and gynecology adolescent practices can be given to the patient. Life's problems wouldn't be called hurdles if they weren't a way to get over them. So by interdisciplinary approach, we can treat any case of heavy menstrual bleeding in adolescents. Thank you so much.
Very nice.
Thank you very much, Dr. Chandan Kachru. It was an excellent talk. I want to add only one point that in our part of the world, genital tuberculosis is one of the causes, and if other causes are ruled out, it should be thought of to rule out genital tuberculosis also.
Yeah, definitely.
Yes. Your talk was excellent.
Thank you, ma'am. Thank you so much.
And thank you, Dr. Chandan, for bearing. She shifted her talk later on because she was in a hurry, and thank you so much for that.
Kiran madam is there? Dr. Kiran Pandey, madam?
I don't think so.
Kiran
I'm
madam not
happy.
joined yet.
Yeah, I'm happy to introduce Dr. Meenakshi Bharat, who is to talk on menstrual hygiene, which is a very common topic. I don't have her CV there, madam.
Madam wants to talk like extempore. She
Yeah.
don't have presentation.
Yeah, no. Her CV is not seen, madam. Dr.
Meenakshi ma'am.
I'm there.
Meenakshi madam.
I'm there.
Actually, the CV, madam has.
Shall I just introduce myself? It's simpler.
No, madam, I'll. Okay, you tell, madam. I would have read your CV that you have sent to me.
Okay, please read it. No problem.
Madam, Dr. Meenakshi Bharat is a gynecologist of 35 years and she has specialized in fertility work. Her medical practice consisted of making it easy for couples to undergo treatment to have children. Prevention is better than cure has always been her mantra. Her other passion stems from this mantra as she looks to prevent diseases created by garbage. From segregation to compositing to using only reusables and having a waste free wedding for her children, she is extremely active in converting people to sustainable ways of living. Having retired from the active medical practice in 2018, she brings her passion for gynecology and waste management together in the campaign Green the Red, advocating reusable menstrual hygiene products like cloth pads and menstrual cups. Her aim is to make all women enjoy their periods and not hate it. So this is all about madam, and she has. Over to you, madam. You are here.
Thank you very much. Thank you for the opportunity to talk about menstrual cups again and improved menstrual hygiene. Thank you, Dr. Parag and Dr. Sunita, for this opportunity once more. I'm here to tell everybody that we can have comfortable periods, we can have happy periods, and we need to introduce the menstrual cup to all women. Before we introduce it to women, we need to use it ourselves. I'm menopausal So I don't have the opportunity to use it, but all of you young gynecologists need to use it. And one cup can last you 10 years, replace 1,000 pads, which is amazing. We use you know, 10 pads a month, and it's equivalent to 100 pads in a year. And this replaces 1,000 pads. So it's amazing that the amount of garbage that it reduces, the amount of irritation to women during the periods that it reduces, and the amount of wastage of money that is there. So let me first say, this stays inside the vagina, and it's made of medical grade silicone, completely compatible. No irritation is produced by using the menstrual cup, and each menstrual cup holds the equivalent of 3 pads. So a pad holds only 5 ml, only 1 teaspoon of blood, but this holds between 15 to 25 ml of blood. And this menstrual cup avoids you from changing every 4 to 6 hours. For those who have, heavy menstrual bleeding, this is the biggest boon. But for all women, it's a boon because you have nothing between your legs and there is no irritation, no itching, no feeling of wetness, and no infection. That is the advantage of the menstrual cup. And the fact that you're wearing this cup means that you can pass urine and stools without removing the cup. So basically, a cup can be used for 8 to 10 hours, but once in 10 to 12 hours, you need to press it, remove it, drop the blood, wash it with plain water. No need for any sterility because the vagina is an unsterile organ. So, if we understand that the vagina is an unsterile organ and we don't clean our partners with hot water and soap before intercourse, then we will be able to use it without any hesitation in our mind. So, the cup is made of medical grade silicone and is absolutely inert in the vagina. Dr. Nair, you are in WHO. I want you to take it up and tell WHO that they can make women happy across the world by just using these menstrual cups. And for me, I advocate a menstrual cup without a stem, because the stem has this temptation to pull, and when you pull it, it doesn't break the vacuum that is created in the vaginal wall. So if you don't have a cup, if you don't have a stem, then you press on these grip lines that are available and pull it out with ease. So that is one of the important things that we need to tell people, that use a cup which has a capacity, because it is U-shaped and doesn't have a stem. There, it's very comfortable. And when you are even riding a scooter or riding a horse for that matter, wearing a cup does not in any way give you any trouble. So women need to understand, and if the gynecologists start using it, then they will be able to propagate it, because like Amitabh Bachchan says, पहले इस्तेमाल करो फिर विश्वास करो. अगर आप इस्तेमाल नहीं करेंगे तो विश्वास ही नहीं आती है. So this is the game changer for the whole world. One cup costs nothing more than maybe $3 to $4, and the cup that is there can create no garbage, no infection. So all the problems that are created by the disposable sanitary pad, the trash, the rash, and the cash is all removed by using this menstrual cup. So I seriously advocate every gynecologist to use it for your own comfort. You don't have to worry about anybody else. It's your personal comfort to use it. And if you are menopausal like me, then you need to introduce it to your daughters in law, your grandchildren, and everybody. The women who work in your house, everybody, if you introduce to them, they will forever bless you for giving this as a gift. It's my favorite gift to be given to every girl that is getting married. I don't think she will ever regret getting a gift like this. So please do that. It makes a lot of sense for everybody, and especially for the athletes. The athletes have a cup which is made of more tensile strength so that it doesn't get, crushed by the by the more strong muscles that women athletes have. And once this is used, there is absolutely no problem. So there are different tensile strength: the soft cup, the medium cup, and the hard cup. So for young girls, if you use the soft cup, with this has a stem, but actually this one is a soft cup which girls can introduce very easily. And the other thing that I would like to say is, as we go around talking about health to women, we need to, talk to the younger girls and say that you need to learn about menstruation way around when your teeth fall off at the age of 7. So mothers and fathers need to sit with everybody in the family and explain what is menstruation. And having explained what is menstruation, then they will be aware of it and it won't come as a shock. All of you have explained that the Tanner system tells you when menarche would be starting. We need to tell that to all girls who are in school, and that starts with where by the time they are 7 years old, that means fourth standard. Pads have a whole lot of problems that are created because of the contents of the pad. Every pad contains cellulose, and the pads, when thrown into the pots, will swell up and block the drains. So that's another advantage that we have when we use this menstrual cup. This is only 5 grams, 15 grams of weight, while the pads in 10 years will be 35 kgs of disposal. So if we can use the menstrual cup, it helps in keeping the environment clean also in a big way. So for all younger girls, the cloth pads have come up with special design which has a jacket at the back for the younger girls because they're scared of inserting it inside. There is an inherent fear that our hymen will rupture. Now, all of us as gynecologists know that if our hymen didn't have a hole in it, we wouldn't be getting our periods and it would all become cryptomenorrhea. But if we can tell the girls to use the cloth pads initially for the first 5 or 6 years, then they will be able to get to using it. And this newly designed cloth pad has a jacket at the back which prevents the other clothes that you're wearing from staining. So this also is like the disposable sanitary pad, only holds 5 ml. So we need to understand that and explain it. The other thing that we need to tell the girls is that there are 3 holes in the down under. We have one hole for passing urine, one hole for passing stools, and this cup goes into the middle. The cup is not useful for incontinence, urinary incontinence, because it holds only 15 ml. But we bleed only 60 ml, and very nicely, heavy menstrual bleeding has been stated as more than 80 ml. So since we bleed only 60 ml, there's absolutely no problem. The cup can be washed and put back, and you need to wear it in the night also so that you can comfortably sleep and not worry about sleeping on the back. You can sleep on your stomach also, and there won't be any leakage. If you are the heavy bleeding variety, then yes, maybe you may require on the heavy bleeding day to get up once in the night, empty the cup and insert it back again. So one cup lasts you 10 years. In 10 years, you will have used 10,000, 1,000 pads to replace the cup. So it's a no rash, no cash, no trash program, and it is extremely good. Gynecologists are leaders in all places, doctors are leaders everywhere, and if they will use this, then they will find that they are totally comfortable during their periods without any problem. You can run a marathon, you can do an 8-hour surgery, you can stop feeling miserable during your periods if you use a menstrual cup. So my request to all the doctors on this session is to first use it, to tell all your nurses to use it, tell all your nurses to tell every woman who is coming into your clinic to use it, and by word of mouth it will spread to everybody in your community, in your city, in your state. You will be the champion to make periods comfortable for all women. Thank you very much for giving me this opportunity.
Thank you, madam. Nicely you have put us no cash, low rash, and low
Trash.
trash. So very wonderfully you have told about all the benefits of menstrual cup in a very positive way and at a very strong way. I think the message will be reaching every gynecologist and we'll try to disseminate the knowledge. And thank you, madam.
Thank you very much.
Dr. Poonam?
Hello. Dr. Sita, do you want to say something? No.
Thank you, Dr. Meenakshi, for this wonderful talk and disseminating knowledge about this menstrual cup, which is so environmental friendly and very least expensive. And I will promote this to our patients and our young.
Thank you very much.
I would like to thank all the STEAM chairpersons and speakers for this wonderful academic feast, which has satiated our appetite of knowledge. Now we are getting late for post-test, so I would like to hand over the floor to Dr. Supriya Jaswal with heartfelt thanks to Supriya and Parag sir for giving me this wonderful opportunity. And over to you, Supriya. Thank you all.
Thank you very much. The back team.
Yes, ma'am.
Yeah. So now we'll have the post test and the timer will be on. And please do it. It is just posted. The link has been posted in the chat box right now. So the time, it is 15 minutes. Time starts now. Start doing that post test. So we'll just keep quiet till then.
Thank you, Supriya.
Yeah, thank you. So this is the QR code, day 1 MCQs. You just scan and start your post test.
You're doing something with my phone? No.
The link is again posted in the chat box. So you can finish it off and wait to see the answers. So now 5 minutes to go now. Whoever has not completed, please finish the post test. Thank you, share. So 30 seconds to go now. Those who have not submitted, kindly submit. It's really heartening to see so many participants still logged in and sincerely doing the certificate course, doing the post test. Thank you so much. Yes. So the post-test is over. Now, can you show us the answers?
Yes, ma'am.
Hmm. Can you make it full screen?
Ma'am, it is full screen.
Okay. So the font is such a. So the MCQs of today is the questions are, what does LGBTQ stand for? The correct answer is lesbian, gay, bisexual, transgender, and queer group. How can we support LGBTQ individuals? The correct answer is C, by listening to their experiences and advocating for their rights. What is primary amenorrhea? The right answer is B, absence of menstruation in a woman who has never menstruated by age 16. Question 4 is, what is the treatment approach for primary amenorrhea? The correct answer is C, depends on the underlying cause. What are the newer modalities for menstrual hygiene? The correct answer is menstrual cups. Which is the most comfortable product and least expensive to use during periods is disposable sanitary pads. Then what is the primary goal of an adolescent clinic? To address the unique physical, emotional, and social needs of adolescents is the correct answer. Which of the following is an essential component of an adolescent clinic? The correct answer is confidentiality and privacy. Then most common cause of HMB, that is heavy menstrual bleeding in adolescents, the correct answer is anovulation. Then that hormone should not be prescribed for heavy menstrual bleeding in adolescents due to bone closure suspicion. That is it true or false? So it is false. The correct answer is false. Long-term consequences of metabolic syndrome in an adolescent include all except lung cancer. D is the correct answer. Precocious puberty is defined as development of secondary sexual characteristics before age of 8 years is the correct answer, which is a false statement. GnRH stimulation shows a prepubertal response with LH-FSH ratio less than 1 in CPP is the correct answer. Question 14, we have identified the true statement. The true statement is GnRH analogs are mainstay of treatment for precocious puberty. Which of the following statements about ultrasound in adolescent PCOS is true? Ovarian size is usually small, hence difficult to detect PCOS in younger girls is the correct answer. Question 16, what is the recommended test for glucose tolerance in adolescent PCOS? That is correct answer is C, 75-gram oral glucose tolerance test, OGTT. Then 17, some people believe that comprehensive sexuality education encourages masturbation. What would you say? Correct answer is B, that is no, CSE does not encourage masturbation. Then 18th, a 12-year-old girl with an intellectual disability is found masturbating in public. Tick the answer that you think would be an appropriate response from an obstetrician. Correct answer is fourth. Rule out triggers like anxiety, sensory issues, or possible abuse if behavior seems excessive or of sudden onset. Then contraception not advised for teenagers, that is OC pills, is the correct answer. Neonatal complications in teen pregnancy are any of the above, is the correct answer, D. So these are the answers. You can make out how many correct you have done. So thank you for this. And now, back end team, just a formal vote of thanks I would propose. Actually, I'm very happy that today very good registrations were there. And so thank you, the Foxy ICOG certificate and course, the team. First of all, I'll really thank Dr. Sunita Tandulwarkar, Madam, the President Foxy. Then Dr. Parag Binewale, who is the Chairperson ICOG. Dr. Sarita Bhalerao madam, who has been very kind, very punctual in doing all this, and she kept on following us. Dr. Ashok Kumar in absentia, Dr. Suvarna Khadilkar madam, who not only took out her busy, time for the busy schedule and also presented her paper, gave the welcome address. So thank you, madam, and the conveners, the stalwarts of adolescent health, Dr. Sampat Kumari, Dr. Durga Shankar Das, and myself, Then the coordinators, the lovely coordinator of today, Dr. Poonam Lal, who in spite of everything, with a very short notice, she agreed to do this and she has done it very nice. Thank you, Poonam Di, for being here and helping me a lot from since you have joined.
Thank you,
Then
Supriya, for giving me this opportunity once again.
yeah,
I
you have
really enjoyed this.
yes, really. I could see that. And day two, Supriya Arwari, the incoming chairperson for Adolescent Health, and Dr. Radhika Gauri for day three. I really appreciate all three of them. And then all the day one speakers, Dr. Supriya, actually Dr. Sampath Madam had done this, then Dr. Sarita Bhalerao, Dr. Suvarna Khadilkar, Niharika Alu, Dr. Priya Vora, who was also not accepting, but then she spoke so well. She also accepted to come. Dr. Chandan Kachru, Dr. Hema Divakar, Dr. Meenakshi Bharat, Dr. Patanjali Dev Nair, so nice. And everything was so good. All the chairpersons, right from the Vishali Mane, Dr. Meenal, Dr. Bharti Rajshekhar, Dr. Vidya Tobi, Dr. Manisha, then Dr. Kiran Pandey, she couldn't make it, although Dr. Premlatha and Dr. Rita Kumari Jhadi. She is also a very great academician. She will definitely read out and then do the discussions very nicely. Thank you, everyone. The backend team, Mrs. Nilima, and the Foxy team, Shreya, ICOG team, they really helped us a lot collecting the CVs and everything. And thank you all the participants, because without you, no program or certificate course can be successful. Thank you, the technical team. Thank you, everyone, from core of my heart. Thank you.
Thank you, ma'am.
Thank you. So we